Good afternoon, everyone. It's a pleasure to have you all here. All those who are working with the same intention of helping children. We have, I think, packed session of 2 hours, and every speaker obviously will be giving us good insights and solve our problems to have better survivals in our country. I have Miss Sakshi with me, and she will be helping us. She'll be actually introducing, she is our project manager, and she will be introducing all speakers. I'll just share the slide so that we can start.
Thank you so much, Dr. Monica. So let's first begin with Dr. Amita Mahajan. She's a pediatric oncologist and is working with Indraprasth Apollo, Delhi. She will be enlightening us on the topic, and she'll be discussing the topic for standards of care for every child with cancer, and it will be based on the current Indian scenario. Dr. Amita, over to you.
Good afternoon, everyone. And at the outset, I'd like to thank Sakshi and Monica for giving me this opportunity to interact with you. Can you see my slides?
Yes, ma'am, it's very well visible.
Yes, ma'am, it is properly visible.
I just need to go back. Can I just stop share because I'm not able to move them backward or forward?
Please take your time, no worries.
Yeah, no, we just tested that.
Ma'am, can you please go back and then do slideshow? Yes. Yes, just click slideshow and then try to share. Yes, it is working now.
So good afternoon once again. And I'd like to congratulate Monica for her innovative ideas of getting us all together. And I really am grateful for an opportunity to interact with all of you on this platform. She gave me a topic which really made me, think as to what should really be aspirational and what should be essential for every child with cancer in India. Across the world, there is already a lot of data. So I put some thoughts together and I'll share with them with you over the next few minutes. These are figures that we all know about. Every 3 minutes, a child is diagnosed with cancer somewhere in the world. And each year, over 250,000 children and adolescents are diagnosed with some form of childhood cancer. Now, the challenge is that more than 85% of children with cancer and 95% of childhood cancer deaths occur in developing countries that use less than 5% of the world resources. So when we talk about achieving standard of care for every child, our biggest challenge is this, that our large volumes and our limited resources and other priorities that we are still struggling. Of this cancer burden, India accounts for 20% of all the cases. And this recent paper by Dr. Ramandeep and Ms. Bagai, both of whom are speakers in today's session, they really enlightened us that we have been underestimating the burden of childhood cancer in India. And if we go by all the statistics, then there are probably more than 75,000 new cases with childhood cancer every year in our country. Now, the biggest challenge is that only a third will ever reach or are reaching currently a center that is treating children with cancer optimally. So that is the biggest challenge, that if they don't even reach a center, where is the question of delivering standard of care to each and every child? So this is the document that was published by the European Society of Pediatric Oncology in 2009 about what should be the European standards of care for children with cancer. And a document was also published by American Academy of Pediatrics later in 2014, but that really refers to the standards of care in pediatric hem-onc centers. So the SIOP document or the European document is a more holistic standard of care document. And the key elements of this document are that to begin with, there should be organized networks of comprehensive care for children and adolescents with cancer and serious blood disorders within each country. So there should be a hub and spoke pattern. There should be centers of excellence and shared care centers. And in our country, yes, we are not meeting this for every child, but this whole, this system is evolving and it is a work in progress. And I think, despite showing those statistics, we can take great pride in the major strides that we have made in the last decade or so as a community with the support of both the government and non-governmental organizations. The next standard of care that European document suggested is that there should be a national registry of childhood cancer to facilitate research in incidence, survival, mortality, and variation from international recorded data. So we do have some kind of registries in India. They are incomplete, and that's why the statistics we've shared here today are much higher than what can be available from the registries. But some work is happening, and I won't talk more on that because Dr. Ramandeep is specifically going to talk on this topic. So it is something that's in evolution. It's a work in progress. We've made good beginnings, and we can look forward to more progress on this. The document also highlights what the criteria of a comprehensive PHO unit, that it should have diagnostics, all procedural to give adequate cytotoxic, chemotherapy, supportive care, blood bank. So it lists that, and a minimum of 30 patients a year. And I can vouch for that each and every of the 250 centers that is currently treating children with cancer in our country is actually treating a much larger number. And most of these centers do have these facilities. Unfortunately, this number of 250 is just too small for our country. But each of these centers are, again, a work in progress. Things are getting better. But, and with the help of labs, which are, available pan-India. So whatever is not available in-house, I think we are resourceful enough to source it from, outsource it to a lab that can give that facility. The document states recommended staffing levels of the PHO ward and what, how it should be structured, how should the delivery of treatment be given, and all centers, as far as possible, do try to comply with that. So I think most of the 250 centers, except for the staffing, where we're grossly understaffed, but all the other components are there and getting better with time. So work in progress. But it just needs to be extended to many, many more centers to meet this criteria for every child. Now, one thing that we probably have excelled at, especially in the COVID era, is continuous professional development. So this platform has allowed most of us to join national meetings, international meetings, that can help us in whatever skill building, capacity building of individual centers. The other components are monitoring late outcomes of cancer. So we've already begun work on that. This is a work in progress. We are increasingly recognizing the need for psychological and psychosocial care, and now palliative care. So each of these elements, I cannot say we are currently meeting the standard of care for every child, but work has begun in each of these areas, very focused work by committed individuals. So I think it will translate to improving the standard of care, at least in the centers where children are currently being treated. Again, the document mentions about the rights of the hospitalized child, the right to optimal analgesia, age-appropriate environment. Unfortunately, especially for adolescent age group, we are way behind in this. Education, the critical role of parents, and rehabilitation. So again, difficult to say that we are meeting the standard of care for every child, but we are trying to do that. It's getting better. And again, it is a work in progress. So the current reported outcomes for, in developed countries for each of the major cancers, as you can see, is, approaching 75, 85, 90%. And as a group overall, it approaches 83.9%. So are we able to deliver these outcomes? So even in our country, despite our limitation at many of the 250 centers, we are able to match these outcomes, but not in entirety at all the centers. And the challenges for that are late diagnosis because of lack of awareness within the medical community, within the patient community, the stigma associated with the diagnosis of cancer, leading to a delay in diagnosis, then refusal and abandonment of treatment, poor access where a family has to travel large distances because, like I said, for a country this size, 250 centers is just not enough. The cost of treatment, even though there is a lot of support, there is still a lot of cost to be borne by the parents, especially before the treatment starts. Lack of supportive services, which is getting better, malnutrition, infection, even in working in tertiary care centers, we know our problems of multi-drug resistant gram-negative sepsis does account for a higher mortality than it does in developed countries. And for individual state governments, it is relatively still low priority. I mean, we are passionate about it. We want to push this agenda, but one can understand that when in a state of UP, the infant mortality rate still matches that if what it is in Afghanistan and Sudan, the countries or the state government's priorities may be different. But there are other ways, and government is listening to even our agenda or these children's agenda. So these are some of the pictures that, where I do outreach work. So, it is just humanly, medically impossible to deliver the perfect outcomes for these kind of diseases. I don't want to show you very negative slides, but it is still in many parts of our country. This is the stage that patients come in, and most of them we will only be able to offer palliative care. So, a lot of work needs to be done for that. And should we get disheartened that for most of these we are not matching? Well, the European document was published in 2009. And this survey in 2016, where representatives from about 400 units in 36 countries, including 27 EU members, answered this survey, and only 18 countries considered they had full diagnostic services, all necessary drugs and supportive care to treat children with cancer. So if they are still struggling, I think we are we're doing okay, and we will get better and better as long as we understand the problems and find innovative ways to deal with them. Access to best possible treatment, care, and support should not be a privilege, it's a human right. So it's, we can understand both the central and state government priorities may be elsewhere, bringing down the infant mortality rate, malnutrition, diarrhea, pneumonia deaths, but it's still the right of every child with cancer to get the best possible treatment. And we as a community owe it to each child to fight for this right. So let us be the ones who say we do not accept that a child simply dies because he does not have the drugs that other children may have. Let us be the ones that are not satisfied that your place of birth determines your right to life. Let us be outraged, let us be loud, and let us be bold. And I think this platform is one of the platforms to do that. And to be able to achieve all the things that I listed, that have been listed as the standard of care, it takes a lot of effort. It takes the community to come together. This old African verb is very frequently used in oncology because it applies to us as well. It takes a village to raise a child, and it takes a huge, big community to treat a child optimally if the child has cancer. And you can see that most of us will not have all of these under one roof. And many of us do multitasking and play multiple roles to be able to provide comprehensive care to the child, but that is what the child needs. And where do we, how do we get that support? So even though the government does have other priorities, there is increasing recognition and prioritization, and both the civil society and the medical community have been able to push the agenda for childhood cancer forward. And this has led to increased availability of diagnostics. There are a lot of support from individual CM relief funds, PM relief funds. There are other state schemes, and importantly, that this can be accessed by public, private, trust, all sectors. So this government support is not limited to government centers. The role of support groups cannot be emphasized enough, because even in US or Europe, any country in Europe, the needs of a child with cancer cannot be entirely met by government funding. And these support groups are essential to drive healthcare professionals, governments, corporates, and the wider community to come together and rise up to this challenge. I'm pleased to say that over 90 support groups are currently working in India, and Ms. Bagai is here today to, to represent them and what phenomenal work they have done and they are continuing to do. One big part of delivering standard of care is the need for collaborative research. And again, to our colleagues from the pediatric community, the pediatric oncology community has really come together on us. We are under a one collaborative umbrella of Indian Pediatric Hematology Oncology Group. Many studies have taken off with many centers actively participating. Dr. Amandeep, who's on this platform, a lot of credit to him for, bringing this all together. Already we've been able to 29 studies with zero formal funding. So the centers or the study PIs may have raised their own funds, but they have been really zero government funding for this. And we've been able to do this. And now when we will have access to hopefully funds for research, we can just, sky is the limit and we can really take this agenda way forward. So today our challenges in delivering the standard of care to every child is, delayed diagnosis and referral, poor access to care, abandonment, low cure rates, even when the child is reaching because of multiple reasons, and high acute toxicity and later effects. And to be able to meet each of these challenges together, we have to be able to deliver the right treatment at the right time to every child. And I think if we come together, we just keep doing what we've been doing, and we get the kind of support we are getting today from both the government and non-government groups, we will definitely be able to achieve this through your hands. Thank you so much. It's been a pleasure to be on this platform.
Thank you, Dr. Amita Mahajan, for highlighting the main points. Next, we have with us Dr. Pankaj Trivedi. Dr. Trivedi is working as a senior consultant in the Department of Pediatric Oncology with National Cancer Care Institute, Nagpur. And he is going to throw the light on the topic problems in Tier 2 and Tier 3 cities for care. Over to you, Dr. Trivedi.
Am I audible?
Yes, Doctor, you are.
Okay. So as such, I have not made any formal PPT, but it is because I am working here in Nagpur, and it is a Tier 2 city. So from the beginning, I had a lot of experience. The problems what I faced when I started here as a pediatric oncologist, and to reaching the established unit of pediatric oncology. Here I'm working at National Cancer Institute. So I would like to share all those experience with all of you, and it might help others who are starting or who are establishing their unit at Tier 2 cities or Tier 3 cities. Definitely there are a set of problems which are, actually Dr. Mahajan has explained, they are the common problems all over the India, like the access to the treatment or a diagnostic value. But specifically for Tier 2 and Tier 3 city, there are a set of problems which are unique because of their geographical place or the institute where you are working. So in these Tier 2, Tier 3 cities, primarily when the formally trained pediatric oncologists were not working like me, the medical colleges are actually the main centers which are providing the cares to the pediatric population who are suffering with the cancer. So when I came here, the most of the time we are getting the patients, relapse patients. When I visited to the many medical colleges, so there is they have dedicated one area, but they are not actually having a full facilities which can treat this sort of a diseases. They lacking the expertise on that. And that is the few problems that I think many medical colleges are having, that trained personnel are not there, trained specified places is not there, and like flow cytometry or other specific diagnostic methods were not available for them. So I have divided my talk related to the specifically disease specific related to the caregiver, like parents who are having the problems at this level, and as a whole, as a like a geographical place we are working, what they are facing the problems. So to begin with, if I begin, when I begin here in 2017, so we have faced initially, that is specifically a disease or oncology related problems. Like, for example, initially we have a very late referrals. So you may find a natural history of the disease, like retinoblastoma patients is coming with a huge eye mass. Now it is very difficult to treat them. So the late referral and the patients are coming in advanced disease. That was a very common problem in this tier 2 and tier 3 cities. But after making the few calls to the local pediatricians or meeting with them, so there is a little bit awareness. Yes, there is a place where they can send their patient, but definitely it was a great problem that late referral be making them incurable actually, or a best supportive care. So other than this, right now also we are having a few disease related problems, like pediatric oncosurgeons. Very difficult. We have to talk to our pediatric surgeons, but we know that the outcome affect if the specialized person is doing the treatment, or we are asking the pediatric surgeon to do the surgery. So this is the actually main problem we faced in the tier 2 cities. There is a actually pediatrician are the first who are supposed to see this. If I take the example of a leukemia, so many patients who has received the steroid, they are partially treated. It's a big problem for us. So making them more aware about the disease, about the treatment plan, I think will make more obvious things to us, and then we can have a little bit of patients who are not partially treated. The thing is that we have gone through, if the patient is coming, either they have done some biopsy and then they have not actually followed up to what is the diagnosis and how to you are going to treatment. So they have not referred at a right place. Here we found that the people are doing bone marrow, for example, for a leukemia patients, but they are not referring and they are not knowing, yes, we can do then the same sample, we can do the flow cytometry. So there are the technical problems with the treating physician upfront, so which we have to face. And now we are have a collaboration with the IAP and making more and more awareness among the physicians. In a tier 2 city, if I talk about the diagnostic services, definitely we don't have a molecular labs or something for them. For that, we have to depend on a tier 3 cities. Like, for example, if I have to send the sample, then we have to send the sample to Mumbai for even for a FISH or a PCR. So that is and that will delays the actually our decision making. Particularly if I say subspecialty services, as I told recently, for example, we are lacking intervention radiologists which deal only with the pediatric patient, or oncopathologists which are trained in oncology. It is difficult to find those experts in a tier 2 or a tier 3 cities. There is when I started here, we have a team-on nursing. Means they are not well trained. So the nursing is that makes a huge impact or a huge difference in outcome. So then that is also one of the problems, that you don't get the onco trained nurses in a tier 2 or a tier 3 cities. Previously, blood bank was, even in a tier 3 city, blood bank or a blood component is a problem. Now at our places, we are lucky enough to have a component services. Otherwise, we have few patients who has received the whole blood and we are not getting anything in the marrow. Initially, they have some suspicious of leukemia, and after a few days, they come with the frank diseases. So this sort of the problems that is particularly related to the disease or a specific diagnostic services. Now, other than that, we have poverty is a pan-India. So this is all this what now I'm quoting the problems they are faced by the parents or a caregiver. So one is the most important is the fund. The most of the time the pediatric oncology depends on the support either from a government or a NGOs or from private. Here we are dealing with the low socioeconomic strata people. Even if you ask them, okay, we will partially sponsor your treatment, or there is a scheme, but they will not actually go with the treatment because they don't have a daily wages. They have no means to earn this thing. And this is a very frequent cause of abandonment of the treatment. Other than this, we have schemes like MGPJY scheme in Maharashtra, but it is way back. They have not, government have not actually taken a step to upgrade it. So this is inadequately supported, and it's very difficult to support them or arrange a fund for them. So fund is really a problem in tier 2 and tier 3 city where there is not a lot of support system is there. So we are facing that problem, and because of that, now we are trying to ask private partners to come ahead and help those needy and a poor patient. We are trying to actually engage those parents in some other type of employment so that we can give them some sort of daily wages. Treatment abandonment is a problem. As I told you, the poverty is the main. Recently, all of us, whether you are a tier 1, tier 2, tier 3, COVID is a main hurdle for us, and that actually leads to many parents to abandon the treatment of their kids. Another thing is the disease relapse. So when the disease relapse, they thought now it cannot be cured, so they don't turn up. So this is somewhat illiteracy towards about the disease, which causes the abandonment of the disease there. Another thing is the practical issue is the availability of the rare drugs. So if I want to get the venetoclax here, it will be a very difficult. We don't have a proper channel to avail those drugs, which is actually easily available in a tier 1 city. So that is one of the problem we are facing here. Another thing is a registry. So though we with the collaboration of the medical colleges are trying to make those registries, but still in this sort of cities, registry of the patients is a difficult task for us. And another is actually, people may laugh, but even we are working here, many people thought that we will go to the Mumbai, Delhi and take the treatment. So all roads lead to the Rome, and so they are referred to the tier 1 cities. Now we are making them aware that yes, we are also providing those facility or those services. So maybe in a future that tendency of the patients may improve in a near future. So these are sort of some problems we are facing in a tier 2, tier 3 cities. But other than there is a good aspect also I would like to share with you. From last 4 years, we are trying hard. We are teaching or we are training the nursing onco nurses. So now we are able to provide them a standard of care, and we are now analyzing our results, which are at least at a national level results we are having with us. So this is from my side. Thank you, Dr. Monica, to give me the opportunity to talk with the all of.
Thank you so much, Dr. Pankaj Trivedi. It was really nice to hear about the special initiatives that you are taking to train the staff members. Thank you. So now we have Dr. Igatik Tushar with us. Dr. Tushar is the first pediatric hematologist and oncologist in Marthwad region. Currently, he is working as a consultant pediatric hemato-oncologist and assistant professor at MCRI Super Specialty Wing with MGM Hospital, Aurangabad. Over to you, Dr. Tushar.
Can you all hear me and see my slides?
Dr. Tushar, we can hear you. Your slides are not yet visible.
Okay, I will share. Can you see the slides now?
Slides are visible. Would you like to do a slideshow?
Okay.
It's visible.
Can you see the slides? Yeah.
Yes, yes, it is.
Am I audible now?
You are, doctor.
Yeah. Thank you, Dr. Monica, for inviting me for this session. It is actually a different kind of session, I would like to say, that I have attended. And it is a good platform where we all are able to, share the problems we are facing and the innovative ways by which, sort of we have taken our journey forward. So I'm working at Aurangabad, which is just like Nagpur, we can say tier 2 city. And I was fortunate enough to get trained in two best hospitals in India. One was Apollo Hospital, Delhi, and then I had opportunity to work at Tata Cancer Hospital, Mumbai also. While working at Tata in 2015, I realized that there is a region, Marathwada and Khandesh, which belong to rural Maharashtra, where unfortunately there is no dedicated center. And this region consists actually 10 to 12 districts. So Nagpur is one center for Vidarbha region. For Pachim Maharashtra, there is Pune and Mumbai. So for that two regions, the Pune and Bombay are able to cater the maximum patients. But this Marathwada and Khandesh was region, which Aurangabad is sort of a capital of Marathwada region. So 10 to 12 districts, and it was a huge geographical area from where unfortunately patients used to come to Mumbai at Tata. And because I belong to this region, I had always had that curiosity, which were the problems they used to face. So definitely to be away from your home from 6 months and to be in a city like Mumbai was not an easy task for them. So when I decided to go back to my region, I thought that it will be very challenging. It will not be very easy for me. So I was sort of mentally prepared because the kind of work which is done at Tata, I knew it very well that it will not be very easy for establishing even 0.1% of that work at a native place. So with that mindset only, I had come, and when I joined at Aurangabad, I faced the same problems which Dr. Pankaj has already enumerated. So to avoid the overlap, I will just uh, maybe focus on the ways which we try to overcome these problems. So of course, late suspicion and referral was a problem. There was no any dedicated center in Aurangabad for pediatric oncology before 2016. Of course, financial support is always a problem. And most important point, I felt that there was lack of awareness among the doctors and community about the good outcomes. Okay, so even if they used to suspect the patient was referred home, or that much motivation or positive counseling was not done at the primary level where the diagnosis or suspicion was there. So there was lack of sort of positive motivation. So we decided that let's take one step at a time, and early suspicion was a problem. So when I joined in 2016, we sort of had a marathon CMEs across the region. Almost all the districts of the region I had conducted CME. Even at the taluka places I went, we conducted lectures for the pediatricians. Then we conducted lectures for the general practitioners also, those who had done BMS, BHMS. And there we took simple topics like CBC, and through that format, we used to, sort of educate or sensitize the pediatricians that this is not normal. This is not, you should be admitting or you should not be giving transfusion for these patients. This is a warning sign. This is where this child needs referral. This is where the child should undergo bone marrow examination, or this is where even in the solid tumors, for retinoblastoma, for sarcomas, then for bone tumors, we sort of try to create the awareness that this is a red flag sign. We also sort of published, I had personally written many articles in local newspapers in Marathi language about the symptoms, about the good outcomes of the diseases. So this sort of, we tried to create early suspicion and awareness about the disease, about the symptoms, about the facilities which are available at a local center, and about the good outcomes. So then we ensured that we should have early referral. So we emphasize that why there is a need for early referral, because it will reflect in the good prognosis. And if there is a delay, how it can worsen the general condition of the patient, how it can result into the financial loss of the patient, and how the steroid exposure causes increased risk in leukemias. In all this, by example, we sort of try to create awareness. Then of course the second step, when we started getting suspicion, we started getting patients at our center. I was not given a special ward because of course there was no facility available prior to joining. There was no sort of concept of having a dedicated oncology ward. Forget about the pediatric oncology because it is a medical college. There is a wing which is called a super specialty wing, but there also we did not have a special ward or any nurses or all those things were not available. So I had to really push to the administration that these are the immunocompromised patients. We cannot keep them in a general pediatric ward. Neither we cannot keep them with the adult patients. So we sort of somehow counseled the administration, and gradually over the period of 2 years, 3 years, I got a dedicated pediatric hematology oncology ward. Our nurses were not trained. So when I came back to Aurangabad, I had discussed with Dr. Banawali sir, and 2 or 3 years before, they had conducted a workshop for nurses all over the India, and we had sent a few of our nurses for the training for the chemotherapy administration. Uh, I also always take those, sensitization and training workshops for them. Then the junior doctors, they were also not exposed to the pediatric oncology. PICC line care, like Dr. At Tata, Sister Mary is there, and the whole system is set. Even at Apollo, the whole system is set. We were not that privileged, so there was one workshop which was arranged at Rajiv Gandhi Cancer Hospital. So I had sent two of my junior doctors for Delhi, and 15 days they were trained into PICC line insertion, sort of dressing and care and maintenance. When they came back with a certified course, then we encouraged them to train other nurses also. So that we sort of started developing the system of chemotherapy administration, PICC line care. Then gradually, because of the thanks to NABH, that during our NABH inspection, this query was put forward. So administration took it seriously, and we got the laminar flow for chemotherapy mixing. Then of course blood bank needs a push, but definitely we are fortunate that there is another hospital called as Hedgewar Hospital, which has very good blood bank, and it is like a twin hospital to our hospital, so they will always support my patients. So that has not been a much hindrance, even though our hospital blood bank is not that sort of we do not have 24/7 access to all the products, and everything is not available, but it is a 5 minutes blood bank, and they will make it available to our hospital, so that is not a big problem for us. So this is how we started with the ward, with the nurses, with the doctors, with the chemotherapy administration department. We have now procedure room. So this is what currently we have. It is a 17-bedded pediatric plus oncology ward, and we have two divisions of pediatric separate and the adult separate. We have dedicated nurses now. I have got junior doctors also along with me. So that has sort of given a confidence to us now that okay, we at least have the infrastructure wise, we are a little bit ahead now. Of course, the third problem which we faced was the financial support, and this was the biggest problem I faced. When I came back in 2016, I used to diagnose the patient, I used to counsel the patient, and used to tell the cost of therapy, and 80% of them were not affording. And then I used to call social workers at Tata, Claret, Rajesh, and Bhagyashri and all those people, and used to tell them that, see, boss, this is my patient I'm sending from Aurangabad. Please arrange for the trust file. Please arrange for the accommodation. And I used to feel that I'm doing a good job. I was happy with my job, and that at least I am guiding the patient, diagnosing in time, and without them spending a lot of money, I am referring them to a good center. So I was happy with that. But when I look back at my data after 6 months, and we called the patients which we had referred, unfortunately, out of 10, hardly 4 or 5 used to reach to the Tata, and 4 to 5 used to go home, because they did not gather the courage. They did not have that sort of financial, a little bit of arrangement also, by which they can go to Mumbai and stay there. So then I realized that this is not going to work. Those who are willing definitely will go to Tata. They are, it is the biggest referral center for us. But those who want to stay with us, definitely we should develop some financial support system by which people will stay here. And I'm proud that today, out of 10 patients we diagnose, 9 at least will stay with us, and hardly 1 or 2 patients we have to refer. So how it was possible? The first and foremost help we got from the CanKids, and I will use this opportunity to thank Poonamji, because this was the one NGO which was actually sort of open door for me for other systems. And of course, Dr. Amita Mahajan was instrumental for helping me in getting these things in pipeline. And Tata also. So both the centers where I have worked, they sort of helped me to get all other NGOs. So CanKids was the first one who started working with us. They gave us the social worker. We have a dietitian also from them. We are getting a diet nutritional support ration system also. So we are fortunate, and that most important thing which we got from the CanKid, apart from the financial support, was the social worker. Because once we got dedicated social worker, we could rope in other trust, other NGOs, and all that paperwork and everything which was required. We got one person. Then Leukemia Crusaders came into the picture because I was at Tata, I was at Apollo, so I was already working with Leukemia Crusaders. Then Cancer Patient AIDS Association, Mukul Madhav from Pune, then Siddhivinayak Temple, Shirdi Temple, then Faizam Trust, Tata Trust. So all these NGOs came, and we are having different NGOs apart from these also, who once in a while support us. So now we have been able to reduce cost of therapy from sort of 100% to 90%, 80 to 90% cost is sort of raised. Funds are raised to the different NGOs, and hardly 10% of the fund patient has to support in the start of the treatment. But of course, there is a lot more to be done. Currently also, we do not have in-house facility for flow cytometry, cytogenetics, immunohistochemistry. We need more local NGO support, because when we start the therapy, we do not get funds, and it takes 1 to 1.5 months of the time. And that is the time where we need financial support. So I realized the need that I need NGOs which are based in Aurangabad or Marathwada region, to whom we can access easily, and we will be able to support us in the beginning. Of course, the accommodation is one big problem. Like there are different Sendued home and all these centers near Tata. Even in Apollo, Amita madam used to arrange outside. So that is one problem where we are lacking. I feel that I should have some home away from home or something like that, and we are sort of working towards it. Of course, we need informal schooling during the therapy. What is two things which are missing at my center? I would like to sort of move forward and have this thing is solid tumors. So because there is no dedicated pediatric oncosurgeon, or even the oncosurgeon full time we do not have, so maybe we are lacking in solid tumors. We have not been able to project our center as a solid tumor dedicated center. So that is one thing where we are lacking, and I think that we'll have to take it forward. Solid tumors like sarcomas, bone tumors, retinoblastoma, they are not coming to us. We will have to sort of have one step forward for these therapies. And I think I will be happy to have twinning with the tertiary care centers, and I will request the faculties which are there in this talk that to help us out and sort of take our finger along with you and take us forward, so that we will be able to standardize our therapies, standardize our protocols, and standardize our care. And definitely it will reduce the burden on the tertiary care centers, because if basic things we are able to manage our center, and then difficult cases or challenging or multidisciplinary team where required, those cases are referred, then definitely it will help both the patients and the center also. So with this, I would like to stop here, and I would like to thank organizers for giving me this opportunity and giving this platform to share my views. Thank you.
Thank you so much, Dr. Tushar. Next, we have Dr. Avinash Thumalapallai. He is currently working as a senior medical officer in Kadwai Memorial Institute of Oncology in Bangalore. And he is also working as a visiting pediatrician with Sri Satya Sai Rural Trust, Ralpad Village in Kola district, Karnataka. And also with Anjanai Healthcare Foundation in Madanapallai, Chittoor district with Andhra Pradesh. So over to you, Dr. Avinash.
Yeah. Good afternoon, everybody. Am I audible?
Yes, Doctor, you are.
Yes, sir.
Yeah. I'm not able to share the. My screen is visible. My slides are visible.
Yes, your slides are visible.
Thank you. Thank you. I thank the organizers and the other seniors for giving me this opportunity to talk on opportunities for pediatricians in Tier 2 and Tier 3 cities vis-a-vis participation in childhood cancer care. Myself, Avinash, as introduced, I work as a medical officer at Kidwai Memorial Institute of Oncology, Bengaluru. And this platform, allow me to pay homage to all the pediatricians and even children who lost their lives in their fight against COVID for just 1 or 2 seconds. Thank you for joining me. And it is very coincidental that today happens to be death anniversary of Kasturba Gandhi. The relevance, maybe in the last slide, I can take it up. And what brings me here is my thoughts and my experiences with the latest experiences to the oldest ones. My experiences as a medical coordinator with the Andhra Pradesh Arogyasri scheme, Rashtriya Arogya Nidhi, general duties in medical pediatric oncology and neuroregistration area, and with responsibilities of national quality assurance standards and other 2 areas of work in my native place and near place, which is on a pro bono basis. But this is what has brought me here with my heart. Madanapalli, which is my native place, which falls currently under Chittoor district, saw a bunch of petitions of euthanasia in a local court, and 3 or 4 of the children were children with cancers and attributed to regional disparities in the healthcare. And I am not giving the definitions here; they are interchangeable many a times. A pediatrician who is not working in a pediatric oncology setup or a organization which doesn't have a pediatric oncology unit is a pediatrician. Tier 2, Tier 3 cities are again interchangeable definitions. So we would look at Tier 3 and below, or even Tier 2. And there is a subtle difference between participation and collaboration. We'll see the differences. And with the latest experiences of conducting a situation analysis with collaboration with ICMR, where as a part of one of the team members, the many pediatricians, all of them were willing to participate in the care. They were more than supportive. However, everyone or most of them had a common enthusiastic question: please tell us what to do. So this was a common enthusiastic question and a positive question. So before going to the present, my thoughts, I would look at immediate requirements which are required probably within next 3 months to 6 months. And they are, we require national guidelines for childhood cancer comprehensive management policy, which is endorsed by Ministry of Health and Family Welfare. And the important stakeholders would be World Health Organization, IAP, and INFA, and civil society organizations forum. Another important requirement would be for standardization of the care, that is manuals, standard operating procedures and protocols for early diagnosis of childhood cancer and management of oncological emergencies, shared care and integrated palliative care. Important stakeholders would be again IAP, PHO, INFA, NABH as a body, and National Health Systems Resource Center, which is a technical agency of Ministry of Health and Family Welfare involved in national quality assurance standards implementation at all government health facilities. And the immediate requirement would be a government supported, government mandated telemedicine network to connect all the public health systems, private health systems across the levels of healthcare. An emergent need would be resources at one particular place with a collaboration between the government and WHO and the scientific bodies. However, there are many possibilities in the current ecosystem, which I am sharing now. Before going to the presentation, I would have a short comparison between a pediatrician in his or her practice versus a government organization. A solo office practice can be compared with a health and wellness center or sub-center. A group practice with or without daycare procedures can be compared with a primary health center. A hospital which has less than 50 beds can be compared with a community health center. With more than 50, less than 100 beds, Taluka hospital. More than 100, less than 250, district hospital. However, more than 250 with or without DNB teaching facility, again district hospital, but DME teaching facility, more than 250-bed hospital, a medical college setup of the government organization. So this cancer table for classification table for cancer probability in children is adopted from PAHO WHO guidelines with their good permission, and we have something similar to our IMNSA program where there is the red put under the possible cancer or very severe disease, yellow which says some risk of cancer, and green says does not have cancer, and the assessment and the classification action to be taken, which is documented appropriately. And the government of India as of today says Rashtriya Bala Swastha Karyakramam may be the scheme under which this can be implemented. Pediatricians can definitely take cue of this. And this is a model, proposed model, which has already been submitted to Karnataka state government for adoption, at least at the government health sector. So the care starts from the RBSK system, that is a primary healthcare center, or where the mobile health team assesses, and based on it, the child is escalated to the nearest Taluka Health Center, and then Medical College Hospital, and then referred to a regional pediatric cancer unit, and then to the quaternary units as appropriate. And across these systems, the pediatricians can participate in the care, whether working at a government health facility or a private health facility or a office practice, and ensuring the united platform to facilitate civil societies organizations participation at all levels. Telemedicine can be applied for an effective implementation, which should be a video mode and need to be real time, and it should be patient to core group, where the core provider to core group and health provider to the core group. What I mean here is the patient and the child and the family is connected by the healthcare provider to the higher healthcare provider, not just the patient contacting the higher healthcare provider. And within the existing guidelines, probably early diagnosis of childhood cancer module of PAHO WHO can be immediately adopted, and the scientific bodies can make the necessary recommendations to the Ministry of Health and Family Welfare for guidelines. Meanwhile, IAP textbook of pediatric and neonatal emergencies, which focuses on oncological emergencies, can be used as a guidelines across the systems. And workforce training, we have the beautiful IAP PHOs, PPO. The pediatricians can make use of this, and IAP PHO can reach out to all the pediatricians to be trained under this program. Transport becomes a very vital part. The pediatricians can immediately use state-sponsored transport systems or private transport systems, and ensure that the child is transported appropriately. We have a beautiful guidelines from WHO integrating pediatric palliative care into pediatric practice, which can be implemented across the systems. Shared care model as of today proposed stays like this: the child who is referred by a general practitioner, the pediatrician continues to participate in care, ensures the diagnosis, prompt referral to the pediatric cancer unit or the pediatric oncology center, and again continues to participate in the care of the child until treatment completion, even on follow-up also. This medical certification of cause of death becomes a very important tool in the hands of the physician to show the real-time statistics with regard to childhood malignancies, mortality, or even a suspected malignancy also. The evolving system, which is already into place, where it is unfolding every day, is the NDHM ecosystem, which is now called as Ayushman Bharat Digital Health Mission ecosystem, where all the players involved are connected through a single digital platform. This healthcare providers, government hospitals, private hospitals, regulators, associations, civil society organizations, and even patients, all of them are connected through this NDHM platform, which is going to unfold in few months to come. Probably when the child is referred from one hospital to other hospital, even the slide photographs may be shared. These are one of the beautiful programs from one of the state governments, where the private pediatricians can collaborate in the care of the patients at government hospitals in their time specified by themselves and as per the provision given in their portals. These from government of Andhra Pradesh. And in last 2 years, Government of India has given the opportunity to the doctors to be recognized as entrepreneurs, where as a registration under Ministry of Micro, Small, Medium Enterprises give them the opportunity to avail subsidized loans or highly guaranteed loans for starting new services or new clinics or new hospitals. The most important difficulty would be lack of diagnostics, both at basic level, middle level, and advanced level. A partnership with private labs or government labs or not-for-profit private labs to ensure there is sampling for basic level or middle level, advanced level investigations, which are classified as per minimum standards of medical diagnostic laboratories, clinical establishment at 2010, can be availed starting from a health and wellness center, even up to a district hospital, medical college hospital also. Radiology is also not a problem. A collaboration participation with governmental, non-governmental organizations can provide all the facilities, even at a tier 3 city also, even tier 4 cities also, including nuclear medicine, which is now possible at district hospitals, district centers also in one of the states, it's in Kerala. And the essential medicines for childhood cancers, starting from emergencies like even raspberry case also, can be made available through Amrut pharmacies, Pradhan Mantri Jan Aushadhi Kendra, state government cooperative societies, and other private not-for-profit pharmacies. This is one of the beautiful programs which has been unveiled by Government of India, where a viability gap funding is given to pediatricians, which is announced under this scheme, which is known as Tier 2, Tier 3 city scheme. But subsequently, Government of India has come out with investment opportunities in India's healthcare sector. This guidelines and the next guidelines, that is guidelines for public-private partnership for non-communicable diseases, have been effectively used by 2 or 3 states in India, where the pediatricians, pediatric subspecialists have been given the opportunity to establish their clinics and hospitals in government provided lands at the expenditure of the doctors with highly subsidized and guaranteed loans. This is a document which has been released just few days back from Government of India, reimagining healthcare in India through blended finance. Blended finance. This from Government of India, state governments will be taking it up forward. These are beautiful guidelines where all the stakeholders in the system, hospitals, clinics, civil society organizations, diagnostics, everyone have a capital investment to reach out to the social goals, that is sustainable developmental goals. So all these goals are addressed by a capital investment and the goal-oriented approach of these organizations. And this document, I'm thankful for to my seniors for providing me this document. Development of oncology wings. Oncology wings in medical colleges in both private and government sector can be initiated by the teaching faculty, that is pediatric medicine teaching faculty, where the oncology wings will cater to the needs of the pediatric cancer patients also, at least to start with early diagnosis, stabilization, and prompt reference sheet. And today we have a beautiful private partnerships which have started in last 2 years. Tata Manipal and recently Institute of Sciences and Mindtree co-founders organizations are an example. Even at tier 2 cities, we can come out with medical colleges and giving state-of-art healthcare facilities. And the National Telemedicine Network, eSanjeevani, would be shortly open to the private players also. This can be effectively utilized. Collaboration between amongst the pediatricians and other private partners, not as large as Tata's or IISc, can be facilitated by a beautiful Section 8 of Company Act 2013, where players for not-for-profit, but ensuring that there is a financial sustainability for the services provided by them is feasible. However, as been pointed out by our previous expert speakers, there needs to be an assurance and commitment towards early diagnosis, management of oncological emergencies, integrated pediatric palliative care, and shared care. Starting from the clinic, we stand by the commitment through our NABH accreditation, where we have a written and committed policies. When we have our own hospitals, small healthcare organizations, we start with an entry-level commitment through the NABH certification, and then we ensure that our nursing services are also quality assured. And then if it's a standalone pediatric hospital, then which has an emergency department can go in for NABH accreditation of only the emergency department also. And then we have our hospitals where we start with accreditation of the small health care organizations. an entry level for the hospitals, followed by full standards, that is the 5th standard of NAPH standards implementation accreditation. And the same quality assurance for the government hospitals would be nothing but national quality assurance standards. It's a national certification program. We assure and commit to a better services to our children with cancers at all government healthcare facilities. And research and patient care need to go hand in hand. ICMR and Government of India have come out with a beautiful portal where even a clinic, standalone clinic, can get registered under ICMR 90 and start have an issue with ethics committee and go ahead with the research. And pediatrician is one of the steering person for the care of the child as a civil society platform. Juvenile Justice Act very clearly says child with cancer is a child in need of care and protection. Pediatrician is an important member in the multidisciplinary team involving civil society organizations and individuals. He or she can be part of child welfare committees and local authority to ensure child gets all the care possible. And this I would name it as a royal part experiment, where there is a rural healthcare center established in a rural village, which caters to around 10 villages and one town which is around 18 kilometers nearby. And a house there owned by a doctor couple is converted into rural healthcare center. And a pediatrician can always be part of the as a root for the tree of life, ensuring there is a responsive governmental policy, timely and accurate diagnosis, ensuring effective treatment right from the suspicion to the definitive treatment. And I mean, a very important role in the multidisciplinary care, ensure palliative and supportive care, for family support, becomes one of the qualified workforce by participating in the IAP NTPPO program, ensure available and affordable essential drugs at least for the emergencies in the Tier 2, Tier 3, Tier 4 cities, ensure cancer registry initiation, and continuous participation in rehabilitation reintegration. So many places I have used the word national, though state is a health subject in India, a government, a guideline endorsed by Ministry of Health and Family Welfare would become a guiding document all over the country. So by the term nationalism, I would refer to this book written by Rabindranath Tagore. So we are young and we can keep growing. India is a young country, India can keep growing. And I sincerely thank my teachers, Dr. Appaji, Dr. Christy, Dr. Kulkarni, my family, and Dr. Amandeep Arora, IAP PHO, Pediatricians Madanpalli, my department who has supported me in coming out with these thoughts. And I thank one and all and sincerely ask, like, we can start the journey from good. Thank you.
Thank you, Doctor, for enlightening us with such nice details and information. So now over to you, Dr. Amandeep Arora, for the question answer session.
Oh, wow. I hope you can hear me. Good afternoon to everyone. Good afternoon to Dr. Bhagat and her team for this splendid program and a very interesting list of talks. And thank you to all the speakers who have already given to the talks, and thank you to those who are going to follow, which are equally interesting. I am conscious that we are running 20 minutes behind time, and I'm also keen that we are able to answer some questions. So it's 7 past 4, maybe just give it 3-4 minutes and then move quickly. Can I see the, I know we have some people in the audience. Are there any questions from there? Because I don't think I have access to those questions.
The access has been shared on the chat box, but as
yes, so there are no questions there right now.
Yes,
okay.
yes.
That's fine. So does anybody over here who is among the speakers, Amita, Vinash, Tushar, and Pankaj, or Girish, Dr. Kurkure, anybody have any questions? Poonam?
So, Ramandeep, I have a question which for all the panelists and for everybody to discuss. So what do you mean by standard of care? How do you define what is the standard of care, and how are you going to ensure that the standard of care at each level is actually maintained? So we don't have a system to actually make that happen, assess it, and re-audit it and see that that is continuum that is maintained. which is essentially a very critical aspect of delivery of pediatric oncology services.
Kavita, are you here? You're probably the person to answer this question.
Yeah, I am here.
Please, please.
So Girish, the one document that looks at it from a very holistic point of view is the SIOP document, which has 15 elements. And many of those elements have sub-elements. So that's a complete holistic document of what the center must have, what the country must have, what the family must have, what, so it's a very comprehensive document, and almost all of it is equally applicable. So it looks at, collaborative network, a shared care model, center of excellence model, access to diagnostics, family support, home away from home. So that document is the most comprehensive document. Then there is the AAP, American Academy of Pediatric document, which is what is the standard of care. But that document confines itself to what a PHO center must be to say that it is meeting the standard of care. Does not look at childhood cancer from a national perspective or a holistic perspective. So the European document is still the document I think that most countries use as what they have to achieve as a country to say that each child is having the standard of care.
So Amita, just to continue the discussion, the problem is how do we implement it and how do we actually audit it, in the sense that there are so many people who want to do chemotherapy. It's not that so many people want to do
each of those elements are completely auditable. So say for example, palliative care. I mean, auditable we could do as PHO chapter, but I think most of it will get done as part of lots of studies. So like there is a palliative care study, about to come in. So all of it is auditable, and a lot of it, if you see, is something that each and every center is trying to do. Some we are very good at. So like, for example, one of the elements is continuous professional development. I mean, the last 2 years have been more developing than any, because I think we've just had webinar after webinar. So at some things, I think we may be better than our European or American colleagues, and other things, those are national issues that, we can't solve, but each of those elements are auditable. For example, registry. So, we know the number, we know how many are registered. So we know where the gap is. We know what is the expected number, and we know how many are registered. And as time goes on, we should be able to hopefully narrow the gap, and, we can choose for our centers which elements we would particularly like to audit first, but both nationally, state-wise, region-wise, institute-wise, all of those elements are auditable.
I think the simpler way, if I may just say, a simpler way will be to go state-wise. What Girish sir meant, maybe he was like, if there are suppose 4 centers in Maharashtra, how do we decide that standard of care if they 4 centers are provided to the patient? Am I right, sir? That is what.
So basically, I'm trying to see how we can translate it on the ground. See, in the US and in UK, it is easy because insurance decides that in US, and UK NHS decides that. So if you're not having a good neuro-oncology neurosurgeon, they would never allow you to treat a brain tumor. They would tell you brain tumor has to get referred there. Whereas we don't
I think the work that, like Poonam is here. So CanKids is making an effort to map state-wise and district-wise, where do the children go? What is the expected number? So yesterday, we had a meeting with all the pediatric oncologists in UP, representing public sector, private sector, trust sector, big centers, small centers, and just to kind of see what is the ground reality. So the ground reality is that of the expected number of patients in UP, only 24% are currently reaching a center that treats childhood cancer. So if we are to say that we have to meet outcomes, we have to reach outcomes of 60%, at least 60% have to reach a center, even if we had. So that is the gap. So in that way, we have a lot of data already that, how much each state wise, where the patient is going and what is happening to the patient, what is the abandonment. So there is a lot of information. Now to put it together on, I think Poonam can take that forward because
Just
many of
want
the
to say,
states.
Poonam, I think you raised your hand, so maybe you can have the last word, and then just for the sake of time, not because we don't want to hear what you all have to say, we will move on to the next session. Thank you.
So I just wanted to say that in fact, today with the IPPHO moving forward, INPOG having come, finally got its registration. Congratulations, Ramandeep. I keep saying congratulations about it. And we are also working at CanKids and with the other civil society organizations. We also came together with the WHO GICC India response. And as state governments are coming on board, likewise, I think for the first time, the central government is also wanting to engage in pediatric cancer. So, Girish, I think if we work together on standards of care document, the one that Amita was talking about, we took a crack at it yesterday to say, okay, where are we with it now? If as a community and different parts of the community, we looked at it and created standards of care, I feel very confident that in the next 2 to 3 years, we will start creating social audit mechanisms to see how and where we are. Right. And I visualize that there would be a paper that would come out, let's say, like this year, we worked last 2 years as a community, we worked on Access India, and we did it as a study across 73 centers. I see that in the next 2 to 3 years, social audit, once we agree on the standards of care, we come out with a document as a community. Then the next step would be that we say, okay, let's social audit it. So if your question is, how do we audit it? I think overall, I've been here now for the last 15, 17 years. I see us at that point, whether whatever WHO, GICC, India response becomes will be that which will help us to say, how do we socially audit the standards we are now agreeing on? So I think this year we should focus on agreeing on standards of care for pediatric cancer. So I must compliment Monica for having come up with this topic today. And then if we worked in 2022 on a standards document for India as a community and with all the stakeholders there, I feel like, in another 2 years, Raman will say INPOG is doing a study and let us do a social audit. Thanks, Raman.
Thank you. Thank you. Back to you, Monica, and I think it's Richa. Sakshi, thank you.
Thank you so much, sir. So, since we are done with the Q&A session, now let's move forward. The next set of session, we'll begin with Dr. Girish Chinnaswamy. Dr. Chinnaswamy is presently working as a professor and head of department with Tata Memorial Hospital in Parle, Mumbai. Tata Memorial Hospital is a well-known establishment and act as one-stop destination, servicing patients both India and neighboring countries. Dr. Girish's special interests are pediatric neuro-oncology and bone tumor in general. So over to you, Dr. Girish Chinnaswamy.
Thanks. I'll just share my screen. Yeah, is it visible now?
Yes, sir, your screen is visible. Please do a slideshow.
I don't know, it says your screen sharing is paused. Is it moving, the second slide?
No, it is not.
Not moving.
So, okay, so I think there's some technical problem. It's saying screen sharing is
Sir, you kindly get back from the slide and then try again to do slideshow and then share the slide. It will work properly.
so just tell me again. So just stop share first.
Yes.
Okay, stop share, done.
Then share your screen again.
Okay.
Try to share and then do slideshow. Try to share your screen, sir.
Can you see the screen now?
Yes, sir. Now try to do slideshow. Yes, sir. Resume slideshow. Show.
Still says screen sharing is paused down. What I'll do is that I'll just put it on and I'll just talk because the slides are okay.
Okay, sir.
Dr. Girish, if you want, you can also close the presentation and then reopen the presentation again, and then go for the slideshow from the view option.
Sure. I'll do
Yes,
that.
so you can do that.
Hello.
Yeah.
I may have difficulty sharing my presentation because other people are also, but Abhi, I am 2 presentations away. So, no, I prefer to do it here. You just be here at that time. In another 5-7 minutes, just come here.
Can you see it now?
Hello. Actually, if you're not working on something else, maybe you can come here because I can work with you side by side on other stuff.
Can you see the screen now?
Yes, sir, it is visible. Try to please try to do it in full screen mode.
Okay, I'll
And
just try once more.
yes, sir.
It's pausing again. I don't know why.
One of the doctor has already directed how to do it. Go to the view. Ma'am, can you please?
Yeah.
Yes,
Yeah,
yes,
please go
yeah.
to the view.
Okay.
And there is an option that says slideshow.
Yeah, slideshow.
Yeah.
From top, it will be the 4th one. Please move to your, just go go on the fourth.
Go to the
Please
left.
move towards your left. This is the one. Yes.
Yeah, it's still paused. I don't think it's moving. So it's not moving, right? Second slide.
Yeah, it's not moving. I suggest
in
you just
this
Can you please do resume slideshow then? I hope after that might work. Is it working?
No, I'm just going go to review slideshow. Is it?
Yes, sir. Just try it once if it is working.
Otherwise, we can just go with this. You can see this.
So you can increase the page view from the bottom right of your, yes, a bit less. Yes, this is very visible. So you can, we can present it in this way as well.
Sure. Yeah, so this should be fine. So yeah, sorry about that. I mean, this has been a problem both yesterday and in the class, which we did as well, that somebody was presenting and this was happening. So anyway, I think there's some technical problem with our IT. So the next 10 minutes, what I want to talk about is about upgrading skills through academics and clinical research and how that actually helps to maintain standards, or what is the way we can actually endeavor to maintain standards in pediatric cancer care in the country. So what's the need for standards in pediatric cancer care? As you all know, pediatric oncology is a specialty which is heavily multidisciplinary. So it is practically impossible to do private practice on a single person, like a clinic, to do pediatric oncology on your own without having rest of the multidisciplinary team, either within your center or in additionally with other centers. It's heavily protocol driven compared to many other specialties where there are multiple ways to actually treat the same condition. Pediatric oncology is heavily protocol driven. It's significantly evidence-based, and the evidence in pediatric oncology has come more by need because pediatric oncology is a rare cancer, and there has been a large cooperative clinical trials done, especially in Europe and North America, which has led to generation of level 1 and level 2 evidence on which most of the treatment today is actually established. It's rapidly changing therapies. Obviously, if there are large cooperative clinical trials or cooperative groups, then they would be actually generating more and more evidence and doing trials one after the other. That means there is new therapies or new alteration or new permutations and combinations which are coming up. So real-time upgradation for us is actually critical for us to deliver what is contemporary standard of care. And we need to maintain uniformity of care across the institute or across the region or across the state, whichever frame of reference we want to take, because maintaining uniformity of care is what gives us the best outcomes with the current evidence, and it also helps us to assess the efficacy. So if I do one treatment and the next door somebody else some other treatment, and then the third person does something else, then what is the outcome of this particular tumor in Tata Memorial Hospital will be very difficult to actually assess, or what is the outcome of this tumor in Mumbai will be very difficult to assess unless we all are having some level of uniformity and having some protocolized based therapy on which we can assess the efficacy of the outcome of a particular cancer. it's impossible to actually assess the efficacy of any treatment on individual basis, as in a single child. I saw this and 5 years back, this child responded, so it works well. It would be impossible to do that. For the reason we know that all cancers are so heterogeneous, and treating them on a uniform protocol gives us a proportion of children who would actually respond, rather than it'll be impossible for us to say your child is definitely going to get better or your child is not going to do well. So having said that, maintaining standards of care are easier said than done, especially in a heterogeneous healthcare system as in India, where 80% is in the private sector and 20% is in the public sector. And then it nevertheless is not impossible. It needs to bring together a good partnership between private, public, and the community health service to actually deliver standards or uniform standard of care across the region. So it is rapidly changing times as well. From the time when we started practicing pediatric oncology in India about 14, 15 years ago to now, there are more and more patients who actually prefer treatment closer to home. So which means shared care is becoming more and more important now. And there are, for obvious reasons, it's practical. They can continue with their livelihood. Other children and family members can be taken care of, and it definitely prevents abandonment. Which means that we not only have to maintain the standards, not only within a pediatric oncology referral unit, but we also have to maintain the standard across your shared care units or where you're referring children. And that's why to define that standard of care, what has to be done in a tier 2 city or a tier 3 city is extremely critical for us to see what can be delivered. So it has to be a collaborative joint effort to deliver care. And that is the times we are living in now. Access to information is far easier. So it is a good and a bad thing at the same time. A good thing is because then people who need access to a latest treatment or a latest protocol will get it through the internet now. But at the same time, the problem is that a lot of it is unedited information which is available on the internet, and you do not know what works best in your region. And if you want to actually deliver uniform care across the country or across the state or in a particular region, it's better that there is actually consensus on what we actually want to do in that region. We must remember that there is more legal recourse sought by families now, especially the type of treatments we do, because they have the access to the information as well. And this legal recourse is only likely to increase, which means that we cannot no more compromise on the providing the minimum standards of care which is expected for a particular cancer in India. It's no more acceptable. It is no more acceptable that we actually do not do cytogenetics in an ALL, or we do not do flow cytometry in an ALL, or we do not actually state the disease completely, or we don't do NMYC amplification in neuroblastoma, for example. So that's no more acceptable. I think it's only a matter of time whether somebody would seek legal recourse if we actually don't do that, and we don't have justification valid for not having to do it. Hence, it's critical that we need to be updated with latest information, and that does not apply just to the pediatric oncology referral units, tertiary centers. It also applies to the tier 2 and the shared care centers, where this information, the local doctors who are delivering care, even though in a shared care basis, need to have that information so that they can actually appropriately treat the child. So how to be updated? I mean, you have huge ways how this can be done. So there are short-term courses which are there for all cadre, and that applies for not only doctors, applies for paramedical staff, nurses, pathology technicians, radiology, radiation technicians, who can all undergo short-term courses, so that wherever the center is being established, the basic methodology, the protocols, and the delivery of care is actually trained and certified, so that they can actually do that. Then there are midterm courses. These are mainly for people who are already established as a pediatrician or a senior nurse, etc., who would like to come over to a referral center and learn when you want to establish a new unit. So it can be a 3 to 6 months or 6 to 12 month courses where you get trained in basics of pediatric oncology, delivery of care, chemotherapy, etc., but may not have all the multidisciplinary team in your center, but you may be able to do substantial amount of work there. Then there are fellowships for people who want to do a career pediatric oncologist or want to get substantially more trained in pediatric oncology. And then they would actually do a 1-year fellowship like the IAP or the 2-year fellowships which are there from the PHO. And that would give them a substantially more grounding in pediatric oncology. And they would be actually able to go and establish to a large extent, able to do 80 to 90% of the care required to be done in pediatric oncology. So we must be having some backup on why we are basing the delivery of care or treatment, what we are doing, and there are many guidelines which are available. The government guidelines being the ICMR guidelines or something like the National Cancer Grid guidelines, which get updated frequently. And these guidelines would help us to actually have a backup or support of why we have selected this kind of treatment. And that would be the reference point which many of us can use. There are, of course, intense pediatric oncology courses, FNB, DNB, DM, which can be done, which people would want to do and take a full-time career, either in and set up a whole unit on their own, delivery of most aspects of pediatric oncology. But that is only there in certain centers. And many of them may not want to do full-time pediatric oncology, but however want to participate in shared care. And that's why in that situation, the fellowships and the midterm courses would help. Internet, as I already mentioned, has got a vast amount of information which is unedited, uncontrolled information in the space. And unless you actually know how to judiciously use that information, you may actually end up delivering something which was inappropriate or may not be deliverable in our setting. So I think we must know how to judiciously use the information to stay updated in pediatric oncology. So how to deliver appropriate care? So this does not apply to obviously tertiary centers. If you're in a shared care center, which many of them spoke about, you would liaise with your local pediatric oncology team, which would be your tertiary center, which may be in the same city or in a different city. You may want to collaborate with other centers for care. So it doesn't have to be that the patient has to leave a tier 2 city and come across to a tertiary center, say for an orthopedic surgery. If you have a good orthopedic surgeon who can actually do orthopedic surgery with oncological principles in another center nearby, you could liaise and do that. For example, we ourselves do not have enough bone marrow transplant beds with us, and we ourselves liaise with centers in Mumbai and do 3 or 4 times more bone marrow transplant than what we would do in Tata Memorial Hospital in the peripheral centers of Mumbai. And it is just we collaborate so that we can give the appropriate standards of care. I mean, it would be inappropriate not to do transplant for a relapsed AML. It would be inappropriate not to do transplant for a T-cell ALL who is relapsed, for example, or not to do high-dose chemotherapy for a neuroblastoma. And if you don't have the facility, then we cannot say anymore that we don't have the facility, that's why we didn't have the capacity, that's why we didn't do it. So we have to go ahead and establish the standard of care, which may require partnerships with other centers, which is exactly what needs to be done. It is critical that the protocols that need to be followed between the centers, primary center and the shared care unit are written. The flow sheets are very clear and shared, and documentation of the delivery care of is done, and that has to be made mandatory. All the assessment points and review procedure must be pre-specified so that we know exactly what assessments are done in the local center and what assessments are done in the tertiary center in case a surgery or any particular treatment has to be done there. So that kind of framework or that kind of machinery or standard operating procedures have to be set in place to actually deliver uniform standards of care across the region. So coming to the next aspect of what should be the role of research in present day clinical practice of pediatric oncology. So we all know that clinical research started many years ago in the 18th century when James Lind, who was a surgeon, actually identified a problem from his job. He was actually a naval doctor and he was on the ship, and he noticed that many sailors actually died of scurvy. And then there was various treatments which are being put out. There was no internet, obviously. So someone spoke about giving vinegar, someone spoke about giving alcohol, someone spoke about giving lime juice as well. And someone had told that giving lime juice actually improves the scurvy symptoms. So he decided to just do a simple clinical trial. So he had a problem which was there in front of him and did a clinical trial and established the evidence that vitamin C and the link between vitamin C and scurvy, and said that if you actually give all the sailors on the ship with lime juice, they would actually get better, or the scurvy would be avoided and they would be able to continue on their voyage without any problem. And that was the first clinical trial which was done, which a limited sample size of only 12 patients to actually show that vitamin C actually made an impact. So what I'm trying to say here is that we cannot escape from clinical research, whether we are a primary pediatric oncologist or whether we are actually in a shared care setting. So this was one of the medical educationists view who said that everything we know now, everything that we can do and everything that medicine has to offer for improving health is based on research. So those who imagine that we can get along without supporting medical research are deluding themselves. So in the sense that medical research is not privy only to the people who are in tertiary units. So medical research has to be done across the community, across the country, across the region. because what has to be done is actually to assess the impact of any therapy or any intervention in a real world setting. And that can only be possible if all stakeholders are actually involved in the conduct of the research. Now, does research actually make an impact at all? So do children on clinical trials actually do better? So we always are of the view that children who are on clinical trials do actually get much better care. And yes, sorry. Okay, can you see my slide still?
Yes, we can.
Yeah. Okay. So children on clinical trials do better. Children on clinical trials are thought to be was always perceived that we would do better. So this was a study from the American Cancer Society who actually matched children, did a match cohort of children who actually agreed to go on clinical trials and who did not go on clinical trials and were treated as standard of care. The red thick line, what you see of children who are treated on a trial, and the blue thick line are children who are treated on standard therapy without being on a clinical trial. Though you do see a gap, overall, when you did a statistical analysis, it did show a trend towards better improvement, but there was actually no statistically significant difference between them. But nevertheless, what the experience has been by cooperative groups across the world is that if children are on clinical trials, the outcome of the children is much better. So which means that we must encourage that everybody participates or every child goes on to as much as possible on a clinical trial, even though it may be just a standard of care, data collection and delivery of care, because that actually improves the supportive care and the delivery of care of these children, which actually translates to a better outcome. So advantages of conducting trials is that we are able to answer questions which are generated in clinical practice, especially in our setting. So a lot of the questions which are answered are from the Western world. And the quality of care is better on trials, as we did see, and it's predefined procedural methods. There is contingency management. What happens if you get a thrombosis with in an ALL who is on asparaginase? What happens if you get pancreatitis? What happens if you get hyperglycemia? All these are predefined when you're on trial. So then the advantage of that is that you're able to deliver uniform standard care across all the children who are on trials when they get these complications. So the outcome is much better and you're able to also assess it, the efficacy of that intervention. It's generally more evidence-based because all these trials would have gone through extensive peer review and approvals before they're actually used in day-to-day practice. And you get access to obviously latest therapies. So some of the trials, especially which are led by industry or sponsored trials by the pharma industry, gives you access to the latest therapies, which may not be otherwise available for many people in the country. So that is a byproduct of being on a clinical trial. And overall, it improves outcome in the field in a local setting. So that's a huge advantage for people for us to actually think about enrolling more and more children in clinical trial. So this also helps the individual, the doctors who are actually participating or putting their patients in a clinical trial. It helps to collaborate and network well. It helps to interact with the experts in the field so that it only is not only enhancing knowledge, it also helps you to deal with critical situations. You have the sharing of latest information and knowledge because the trials are usually written with updated information which is available globally and it on real time gets updated as well. So you get to get that information, especially if you're dealing with that condition in your setting. Trial methodology experience, which is critical for any oncologist, whether you're at a tertiary center or in shared care setting, including child advocacy, ethics, monitoring, implementation of research, etc. And obviously, many of the people who do run trials or who are part of the trials or contribute patients will get as authors to be on a publication, which is again a career advancement initiative. So conduct of research is not easy. So you will have to get local IEC and IRB approvals and standard operating procedures you must be aware of, which is being followed by a local IEC. So all of the people who are actually delivering or conducting the research will need GCP certification. And the ethics of conducting research in children we must be aware of so that we actually don't do any harm to the children who are participating on the trial. And training on the trial procedures, etc., will be mandatory before we can actually start doing the trial. So there are various ways how we can actually undergo research methodology training, and that is actually part and parcel of any oncologist, not just pediatric oncologists in the present day today. The first is that we all have to be GCP certified because only then we can actually enroll children or patients onto a trial, and that needs to be recertified every 2 to 3 years, depending on which certification you have done. it is good to attend short-term research methodology workshops. So we actually understand the basics of actually delivering it. These short-term research methodology workshops are useful only for delivery of a trial. It doesn't is not intense enough for you to actually develop a complete protocol from scratch. But it helps you to understand about GCP, it helps you to understand about consent, it helps you to understand how to deal with this serious adverse event, how to enter data, why we have selected this, what happens if this problem occurs. So it helps you to understand those aspects. And there are, of course, intense clinical trial development workshops, which are quite a few now, including things like the Credo, the Aspire workshop, the international workshops like POEMS, etc. All of them run workshops as well. And all of those teach you clinical research methodology well. You can take a concept of one of your ideas and develop in this workshop to a complete full-fledged protocol. The best way to actually learn clinical trials is actually be part of a trial team. I think if you initiate trials, you go through the rigor of developing a protocol, go through the criticism of your protocol, develop it, refine it, and finally submit it, and then deliver the protocol or do the trial. That is the best way to actually become a clinical trial specialist in pediatric oncology. And that does take a lot of effort. And the first one is the most difficult one, and subsequently you actually get better and better. So a way forward, the easiest way forward or the next step would be for all pediatric and pediatric oncologists to be part of national and international cooperative group. So we already spoke about INFOG, which is the Indian National Pediatric Hematology and Oncology Group, which will now take a major leap in actually delivery of and conduct of the research, especially clinical research in the country. And everybody can be can become, every institute and every center who is dealing with pediatric oncology care can become part of it and initiate trials. So it doesn't have to be initiated by large centers. It can be initiated from a shared care or a smaller center too, and take the lead and get the people who are interested onto the trials. There are other organizations, of course, all of you know about PHO. There are organizations like Neuro-Oncology or Musculoskeletal Oncology Society in India. And of course, international group like the CCLG, Children's Oncology Group, SIAP, etc., which also will be involved in clinical trials. So these are various ways how we can actually advance your research methodology training, conduct of trials, which all ultimately helps to actually deliver adequate and a good standard of care in childhood cancer treatment delivery across the region, both at a primary level, at the secondary level, as well as at a tertiary level. So I think that is probably my last slide, and I think I'll stop here. And we can go to the next one.
Thank you so much, Dr. Girish Swami. So next we have with us Ms. Reha Mehta. Reha Mehta, she is working as a special initiatives with Mumbai. Reha manages strategic partnership and special initiatives for TMC and CG Navya. Navya has built a machine learning system that has scales access to expert oncology opinions. So over to you, Reha.
Thanks, Akshi. It's an honor to be here on behalf of TMC and CG Navya. Can everyone hear me okay?
We can, very well.
Great. Yeah, thanks for having me. I think it's a pertinent time in the conversation to start talking about, the use of technology and bridging outreach, because what we've heard over the last, 90 minutes or so is the constraints in tier 2 and tier 3 cities, the importance of a local ecosystem and the significance of standard guidelines for care. And I think all of that is a great segue into I think I'm having the same problem as the other speakers. Yeah. It's a great segue into, the way Navya is thinking about leveraging technology. And what I mean by that is, when we built out a technology service or a technology offering to try and bridge access and care, the sentiment or the thought process behind that was to use technology as an integrated offering with a very human-centric service, and to allow it to lean on the existing ecosystem of care, which is, expert oncologists and local ecosystems and NCG guidelines and standards, and to bring in technology as an enabler to work within this ecosystem to offer timely treatment decisions. And I can explain what I mean by that and what, the Navya service actually does. But just go over the context a little bit. Sorry, I seem to be having the same trouble. But to go over the context, I think in a nutshell, one of the biggest constraints that our country is facing is just that there's this terrible dearth of expert oncologists, right? There's not enough specialized oncologists, and particularly pediatric oncologists. And the oncologists that we do have are very concentrated just in the metro cities, as we've been talking about earlier in the panel. And to put a pictorial depiction to that, this is a map from patients coming into TMC. And as you can see, they're coming from all across, the furthest corners of our country to get in front of the TMC oncologist to understand their treatment options, right? Again, further exacerbated in pediatric oncology because they have fewer local options, fewer specialized pediatric oncologists in tier 2, tier 3 cities, rural towns and villages. So they come in to academic centers, metro centers such as TMC to get treatment, of course, but also just to understand the correct course of treatment, right? So what patients want is they want access to the right experts to tell them what to do. So oftentimes they go back to their local treatment centers and local oncologists to undergo the treatment, but they're coming in to understand their options. And this is often perceived as the single most expensive value item in healthcare, right? And the reason for that is what the patient spends on surgery or radiation or chemotherapy depends on the treatment plan or the treatment option that they get. And experts want to offer this accurate treatment plan, right? They want to focus on critical decision making. They want to do it quickly because, experts in the big metros, in the smaller towns, they're just swamped with patients. They're seeing 60, 80, 90 patients a day. And what ends up happening is they spend most of their time going through just a variety of reports, right? Handwritten reports, different formats, different images, WhatsApp pictures of images, which just becomes a hugely time-consuming effort to consolidate all that information. And that actually sets up a great platform for the use of technology, right? Because what we're trying to do with Navya's machine learning system is we're trying to automate several aspects of this process that tend to be a strain on oncologists or physicians, and use technology to synthesize that information. So to collect these different reports, to standardize their format, to tag them in a specific way, and then to feed back to the treating oncologist a very easy to understand patient summary that the oncologists can then use to advise patients on their treatment plan. Okay, so I'll tell you how that works. Why don't I pull up the process so we all have context on how the Navya system works. And like I said at the start, it's a very technology-centric offering, but it's wrapped in this package of a human service. So patients come to Navya, either directly through the website, through referrals from NCG centers, through a number of NGOs that we partner with to send patients our way. And then we've got a team of people, service personnel, who interact with the patient. They walk them through the process, they understand their reports, they help gather a lot of the information, right? So patients may have a blood test, but not x-rays, or they may have scans, but not, other medical reports. And what Navya does, we help them collect and assimilate those reports. So that's now happening by, junior level clinical personnel rather than the treating oncologist or, already trained doctors and research fellows at hospitals. We then take that information and tag it in a specific manner that allows us to feed it into our machine learning system. So we then feed these reports in, and what our machine learning system does is it essentially runs 3 engines. So one is an evidence engine, which looks at, all the published clinical trials since 1970. So that's using technology to do something that's very, very difficult for a human to keep on top of, right? Understanding the latest clinical literature out there. We then look at the experience engine, which is outcomes of similar patients, so hundreds of thousands of patients, treated across NCG centers in India. We look at the outcomes that would be most relevant to this patient we're treating. And then we look at the patient preferences, right? So the choices and the constraints the patient may have. And what our engines are basically doing is it's leveraging these, thousands, hundreds of thousands of data points to come up with a proposed plan that adheres to guidelines. We've been talking about the importance of guidelines, and creates a very nice structured case summary that makes it very easy for the oncologist to quickly skim through and opine on. So our system shoots out the structured case summary, which we then share to one of the experts on our panel. So we've got about 300 experts on the panel who will look at the structured case summary and provide their opinion. Yes, this treatment makes sense, or no, it doesn't, and this is why. So this is a view of what this case summary looks like, right? Compared to looking at a variety of different reports in different formats. What oncologists now see is this clean summary of what the patient, the patient's history, and then these options that our system has proposed in terms of, given the NCG guidelines, given the patient's preferences, given other outcomes we've seen in the past, here's what we think the proposed treatment plan should be. Which one would you go with? And the expert opines. And then again, someone from our team, writes out that report in a very easy to understand format for the patient. And this, using technology in this application also becomes very interesting because it allows multidisciplinary opinions, right? So radiologists, surgical oncologists, medical oncologists can all come together and look at a standard case format and provide their opinion. So it's essentially a virtual tumor board that is asynchronous. So it doesn't have to be, a set Tuesdays at 3:30 hospital meets to have a tumor board. It can be, experts from anywhere across the country or anywhere across the world looking at the same case and sharing their opinions. And we've had the opportunity to prove the impact and, validate this technology from way back in 2014. I know we're a little strained for time, so I'll just take you through some of the highlights. The most recent one being, at ASCO 2021 and relevant to this audience of oncologists, because we did a study with Memorial Sloan Kettering Cancer Center oncologists who used the Navya case summaries, and they presented that it took median time of less than 5 minutes to review a case and provide an expert opinion, right? So now when we're talking about scaling access to experts, the best way to do it is to minimize the time spent on cases, thereby allowing them to see many more patients. So that was a huge time saving for the treating oncologist. Similarly, from the patient side, time saved on travel. Like we've been talking about, like we saw on the map, patients travel far and wide to come in front of an NCG expert and get an opinion. With a virtual offering, they can save, huge amounts of money in travel, and they can save huge amounts of time rather than just showing up outside a metro center and, lining up, waiting for the doctor to see them. They are now getting this expert treatment plan within 24 hours most of the time. And now when you take that application and see, what's the on-ground reality? Like, are we really changing care on ground? What we found is, a vast majority, 72% of patients actually share the TMC NCG Navya report with their local treating oncologist. So this could be oncologists, in the town centers that we've been talking about, could be oncologists at large metro centers as well. And about 78% of the treatment decisions that we offered were actually the final treatment decisions received. Okay. Now, when you think about the implications of that proved to be fairly vast, right? We found that with these standardized treatment plans, right, looking at evidence, looking at past experience, taking in a human perspective of a trained, super specialized expert oncologist, we were able to move the needle and increase on-ground compliance to cancer guidelines by about 15%, right? When you look at conventional medical interventions, moving the needle by 4 or 5% is generally considered a substantial win. So to be able to say, we can take treatments and get about 15% more to comply with standard guidelines brings us closer, it's the evidence of technology bringing us closer to a more standardized version of care. And just to circle back, I know we're running short, so I'll keep it tight, but just to circle back on where I started, I think the reason this kind of technology offering has been able to be, this successful on outcomes, on patient satisfaction, on doctor satisfaction, is because we've really married ourselves into the existing ecosystem, right? It's not saying technology can replace certain players in the ecosystem, or technology can come in and change the entire ecosystem, but it's saying, working with these esteemed organizations within the system, right? So NGOs such as ICS, CancerKids, who's here, send patients our way. Experts from these leading MCG centers help us opine on the case, which makes our engine smarter, which helps local oncologists, be in touch with these experts as they interact over a virtual tumor board. And then we've got a lot of significant corporate funding as well, which enables us to provide these expert opinions to low-income patients who would not otherwise have access to, sit in front of an esteemed expert oncologist at a specialized center. So I'll stop there with inspiration from something Dr. Pramesh said, which was, when we talk about technology in cancer care, you can talk about anything from, eradicating cancer or, to treating all cancers overnight. And those are generally considered technology moonshots. But Dr. Pramesh said is sometimes the earth shots, which is leveraging technology in a way that we easily can on the ground to improve the current ecosystem, could have significant benefits in the near future. I'll stop there. Thank you.
Thank you so much, Rhea, for enlightening us with so nice thoughts. I'm sorry, we are running short of time. So next, let's move forward with Ms. Poonam Bagai. And Ms. Poonam Bagai, she is a colon cancer survivor and patient advocate. She has started CancerKids SOS in 2004. She is also vice chairman of Pallium India. Ms. Bagai is actively fighting a war against cancer, and she is passionate about making a difference to causes of childhood cancer and palliative care in India. She is also committed to mentorship of young cancer survivors and young women in the workplace. So over to you, Ms. Bagai.
Thank you. Thank you very much. I'm going to try to put up my presentation in a minute and perhaps go through a lot of it very quickly because I feel like we're really running behind time, and sadly I have another meeting at 5:30 as well. So can you see my slides?
Yes, ma'am, we can.
Yeah, all right. So looking at it more from the social support and supporting channels that support doctors as well as us, as well as beneficiaries. And I cannot move my slides forward. So give me half a sec. Out of the stakeholders, and there are all of us at the table, that's the excitement. Sorry. Yes, it's the right slide. This one? Yeah. I'm talking on behalf of NGOs, CSOs, INGOs, the beneficiary groups who we also represent, as well as civil society. And the excitement, of course, to me personally is that I think we're pretty much all of us now at the table. And that has been quite a journey, but that story is for another day. For those of you who don't know, CanCids is a national society that is driving change for childhood cancer in India, and we work essentially in partnership with hospitals, 121 childhood cancer treating centers in India, and we have dedicated state projects which pretty much cover 94% of the childhood cancer incidence in India. when we look at childhood cancer in India today, it does represent the harshest of inequities. I'm not saying something that we don't already know, most of us, that 70 to 80% children with cancer are still dying in our country. And that really is most importantly because almost 60 to 66% don't make it to a cancer center. So, and often when they do, it's at an advanced stage. So here's the challenge that we have 80% survivals in our country. We have even 90% in some cases. On an average, I would say it's at about 50%, but that's if a child reaches a center. And so when we look at the outcomes, and we've been discussing a lot of it earlier in the session and going forward as well, but these are some of the reasons for poor outcomes. And that which are flagged yellow or highlighted yellow are areas where civil society organizations can offer social support and partner in a more significant way with the other stakeholders to try to make a difference. So when we look at where are we today, and Amita spoke of it in some way, so did the others, we want the same survival rates as worldwide. And our target for all of us as a community is by 2030, can we achieve the WHO Global Initiative on Childhood Cancer goal of 60% survival? Can we ensure that families get access to care and get holistic access to care, which for the moment we are trying more to focus. I think over the last, 2 decades, we have worked as a community to make sure that when families reach a center, they get good holistic care. But now the time has come to start focusing our energies on trying to ensure that there is access to care in terms of early diagnosis and proper referral to the cancer centers. And while we do this, we want to make sure that we at all times look at a rights-based approach, rights-based approach. And that means for all of us gathered here, including the audience and pediatricians who are interested in childhood cancer care in India, we want to ensure patient-centric healthcare for children and their families. This is a slide I like to put up a lot. Thank you, Raman, and thank you, Nikhil Bhakta, for getting us to understand this better. If the incidence of childhood cancer is 76,800, this is what we're looking at. That all our mapping, the Access India study tells us over here on the right that about 26,000 children are making it to a cancer center. If we go by the Lancet Commission, about 50% children are not getting diagnosed. That's 38,400. And in the middle here, that 16,400 is possibly children getting diagnosed somewhere on the referral pathway, but not really making it to a cancer center. And so for me, this is the starkest inequity of it all, that so many children are not making it to centers. And that's the reason for the low survival rate. And that for us at CanKids, for more and more civil society organizations, we want to start trying to create a focus where we're looking at how we can work with you in making that difference. So when we talk about access to care, and Avinash did a great job of explaining this in terms of tier 2, tier 3 cities, we really need to be talking about access to care from primary to district hospital, government medical colleges, to the tertiary center and back home. And across this whole trajectory, we want to talk about the great best standards of treatment, but also shared care and continuity of care at home, and as well, of course, on survivorship. And I know Dr. Purna is going to be talking to us about survivorship in a bit. So when we look at these two models, and in terms of how social support organizations can help in barriers of access to care, then the first model is how we can partner with treating centers to actually enable and provide best treatment, care, and support to families reaching a center. And we've discussed, and the doctor from Aurangabad also, Dr. Tushar mentioned how we can partner together so that we're able to fill the gaps. Because in a low middle income country like ours, a lot of the time it is about filling the gaps. So these partnerships become important, and I'm going to show you in a minute the services that a civil society organization can help with when it comes to partnering at the hospital. But at the same time, civil society organizations can also play a great role in actually helping to drive, provide health information, create the relevant awareness, handhold, make sure that there are well-defined referral pathways, provide that information to all stakeholders, help to build capacities at tier 1, tier 2, tier 3 levels, at primary healthcare center levels, district levels, so that we're actually able to refer patients and children to the cancer centers. So at the hospital, as I said, what do we do? What do all the civil society organizations who are working actually manage to do? We work on social support protocols, often with the social support department of the hospital. We provide manpower. At CanKids, we offer social workers, patient navigators, dietitians, teachers, psychologists, care coordinators, and even dedicated nurses to the tertiary cancer center that we're partnering with. We provide a whole range of social support services, care centers, primarily home away from homes or parent homes. In Mumbai, we also have Kanshala for formal schooling, which we're hoping to take across the country. And a few, maybe not so many, but a few pediatric palliative care centers where NGOs have participated in providing palliative care support. And then, of course, comes the bit about building capacities, promoting and initiating, undertaking, and even supporting research, and then advocating to hospital management as well as to the governments and the treating teams for improved survival outcomes. So here's a slide which very quickly shows you some of the services that civil society organizations can typically help provide in a hospital scenario. And that includes, most importantly, patient navigation, hand-holding. Patient navigation is important. At CanKids, we actually encourage our parents to come back and we empower them to work as patient navigators. These are parents of survivors or bereaved parents who come from that hospital and therefore are good guides if we're able to, and we do build and empower them. Medical support for drugs, diagnostics, therapies, treatment, supportive care, education for the children, very important part of the rights of a health impaired child with cancer, psychological support for the whole family, child life, outings, celebrations, gifts, part of the right of childhood for the child. And then importantly, patient and family education engagement through forums and parent education sessions. Dr. Girish, somebody reminded me the other day that you're the only hospital that has a regular monthly parent forum. And I really want to thank you for that because I think it's important if we want patient-centric care to have parent forums and survivor forums. Equally, civil society organizations can work on continuity of care and survivorship and in palliative care. So I've got stuck again. Yep. In terms of the care centers, there are parent homes, home away from homes. St. Jude Child Care Centers does a terrific job and has the largest number across the country. CanKids has several home away from homes. Dr. Tushar mentioned the need for one in Aurangabad. And we work now towards providing type A, type B, type C HHs, depending on the need and the requirement. But certainly these are not just providing low-cost accommodation, but also actually enhancing the ability of the hospital to look after more children with cancer. So when we are stuck with the idea that we don't have enough infrastructure in the country to manage the access to care that we're talking about, to have more and more children come to the centers for treatment, then shared care that Dr. Girish mentioned, these parent homes, these are ways that we can enhance capacity. We also have the schooling, which we'll talk about some other day, I think. But I would like to share with you also that we are now increasingly able to set up care coordination centers in states. And these care coordination centers can help to coordinate and work alongside treating teams, especially those who are doing shared care or multidisciplinary care across geographies. And that will actually help in the future as well. So coming to the other project that I spoke about, which is the state project, and what can civil society organizations do here? And again, just to tell you that at CanKids, we have been working on 15 state projects. We have 5 MOUs with state governments of Punjab, Maharashtra, West Bengal, Tamil Nadu, and Gujarat most recently. And the idea is how to work with the entire community to improve access to care, to build capacities, to actually increase financing. Amita mentioned we did a meeting with all the stakeholders in Uttar Pradesh just yesterday. And a couple of weeks ago, the IAP, PHO and IAP in Uttar Pradesh, together with the government, launched a childhood cancer advocacy group. So there's really good hope ahead that we should be now able to work on access to care and actually improving referral pathways and moving forward. I've again got stuck. Oh. So when we talk about access to care across the state, right, we're talking about that primary health center. We're talking about how the child would reach or the family would reach. And we did the INPOG study, Access India, where we found that there were many, many instances where families often actually go to several centers before they reach that final center that they're meant to. They often have to go back home, and if we can work on the shared care piece well, then we will be able to enhance care in our country. And again, as I said, these are areas where civil society organizations, NGOs can play a vital part, not just with the treating center, but with all the stakeholders, so that we can actually handhold, we can create better information, we can help with timely diagnosis, we can provide better financial support or access to the financial support that the many government schemes and insurance are providing. We can take care of nutrition, hygiene, education, and actually for me, the most important, someone to hold the hand of the family so that they don't get lost within the system and are actually able to make it back and forth. We can provide resource directories. The one that you see here actually lists out the schemes that are available, lists out the centers that are available in a particular state, mentions the signs and symptoms, and talks about all the hospitals within that state. This one is from West Bengal. And what is heartening is that with our MOU with the West Bengal government, this particular resource directory is now being sent to every district and every primary health center and every government medical college. So at least there is an updated list of where to go, who's the contact person, is that a social worker, is that a doctor, and where families can be told to go, or ASHA workers can be guided in terms of sending children so that they received access to care. So coming to just the last bit of what I wanted to share with you today, out of a list of 110 NGOs that Amita also mentioned, there are 38 who work pretty much exclusively, I wouldn't say exclusively, but they work in a very, very focused way on childhood cancer. Here's a list of some of them, some working in only one city, some working in 2 to 10 cities, and a few who are like CanKids and Leukemia Crusaders, Cuddles Foundation, Indian Cancer Society, now St. Jude India Child Care Center as well, who are working pretty much pan-India. They offer, as I said, just to sum up, patient services, partnering with hospitals, working with governments and stakeholders, building capacities, creating awareness, providing health information, participating or even initiating research, particularly patient-led research or survivor-led research, mobilizing resources and fundraising, as well as facilitating access to government schemes, all of which become important, and partner with the providers. I wanted to talk just briefly about some of the challenges that are faced by NGOs. A big one is often acceptance by the hospitals, sometimes even the beneficiaries, which comes, I think, in measure from the negative image of NGOs, which also sometimes comes from the fact that often they are seen as charities and not always as a significant partner within the care continuum. And where we have been able to establish these partnerships, we have been able to work as equals. We have been able to ensure that gaps are identified and filled, and the NGO itself is able to work in a more productive way in terms of finding funding, as well as in terms of identifying what can be done to help a treating team or to help another stakeholder in terms of actually providing better access to care. Another challenge has been the lack of coordination and collaboration sometimes between NGOs, the need to build capacities and skills for improved support services, and absence of data and evidence which can help with fundraising and demonstrating impact. I want to say that I always have a very grateful thanks to some people, Dr. Ramandeep, the Tata Hospital, Aims in Delhi, the people who publish and publish frequently. When I first started the work that I did, I used to only find Dr. Ramandeep published everywhere. I found that he was sitting in UK at that time, still a registrar, but he was the one whose data we could use and use it for advocacy, use it for pushing for policy change. There are today, with INFOG having come in, there is much more research, and I think that's really, really important for us NGOs rather than having to go and find the information ourselves. So I want to say that, in terms of the collaborations, the FOSCON is something that has helped to bring all the NGOs together, and we have set up a network. It's called the Childhood Cancer India Social Support Network. And between us, we have run national conferences alongside FOCON, and we have also, we run the network, we have a WhatsApp group, we share best practices, and we're together at the table to work together with all of you to actually make a difference in the lives of children with cancer in India. I'd like to end there, and I'm happy to share my presentation if you'd like to share it with others. Thank you.
Thank you so much, Ms. Bagai. So next is the time for the Q&A session. So over to you, Dr. Amita.
I think there are no real questions. So I think on behalf of all the audience and all pediatric oncologists, all pediatricians, I'd like to thank each and every one of the three presenters who in their own ways have contributed so significantly to the cause of childhood cancer in India. I mean, Girish has been a leading force for both INFOG and collaborative work in patient care. Poonam, you've just heard what amazing work she's been doing. Navya, an innovative, novel concept, and filling a huge gap where parents wanted. Sometimes it's just that they've been told that nothing more can be done, but they want to hear that voice from somebody else sitting in a tertiary referral center, and save them a trip to another city for no purpose. So, and I think that Navya is doing a great job. So a big thank you from everyone for their wonderful work and their contribution to the cause of childhood cancer. And I think because we are way behind time, I'd happily quickly hand over to Sakshi to steer the program forward.
Thank you so much, Dr. Amita. So next we have with us Dr. Ramandeep Singh Arora. He doesn't need an introduction, but still he is holding an experience of overall 24 years and currently working as a senior consultant pediatric oncologist at Max Hospital, Max Healthcare Delhi and Gurgaon. He is also honorary head of and quality care research and impact analyst with CancerKids Kids India, New Delhi, and also secretary with Indian Pediatric Oncology Group. So over to you, Dr. Ramandeep.
Hi, good afternoon. I hope once again you can see my screen.
Yes, Dr. Ramandeep, it's visible.
Okay, so I will go fast, and most of it is graphic, so please bear with me and keep up. Thank you for the invitation. This talks about why every child with cancer matters and counts. And you have heard Poonam talk about some of the data, and I want to show this in the coming few slides. So let's take how every child is counted. If I'm a pediatric oncologist, which is PO, in my hospital, and I see patients, I then start capturing them and putting data. We all like to capture data. It may be files, it may be an Excel sheet, or like in my case, I use Resonance, which is a great platform, and there are other platforms as well like this. Now, I may have two other colleagues in my department or another department, so they start putting in the data, and slowly our hospital-based cancer registry starts building up. We then want to become better, so we may have somebody who's a 15-year-old or a 17-year-old who may be with the adult oncology services, so we pick that up. There may be a pathologist, we'll pick that up. So that starts making my hospital-based cancer registry data complete, and I start to capture most patients. Now, if I'm in the city of Delhi and I feed the data into the population-based cancer registry of Delhi, my hospital is one of the hospitals. Similarly, there are other hospitals now, and they are putting information in this population-based cancer registry. The population-based cancer registry wants to be more comprehensive. It reaches out to mortuaries, it reaches out to pathology centers, it reaches out to radiology centers, and starts capturing information outside hospitals. And that is how it becomes more and more comprehensive. Now this Delhi population-based cancer registry wants to feed to the National Cancer Registry Program and says, okay, what happens in Delhi happens in the country. That may be true, but not completely true. So the National Cancer Registry Program says, okay, we will now start capturing data from more and more and more population-based cancer registries. And that then says today, 10% of India reports to National Cancer Registry Program, 90% doesn't. So NCRP takes this 90% data and creates an all India picture. And that in essence is how every child is counted, and we get an answer that there are X number of children with cancer in India every year. As you would rightly guess, each of this step has challenges, and I'll come to that in the subsequent slide. But why are we doing all this effort? We are doing all this effort because we want to know what is the burden of the patients. We want to know what are the outcomes, whether it's survival or mortality or abandonment or whatever. We want to then say, okay, if I want to improve, what is the metric to target? And if the metric today is 20%, how much percentage do I want it to improve by? And then how am I going to measure my progress that in 2030, when the WHO GICC has a target, where am I? So for all these things, you need to have data on every child. And that's why you've got to count every child, because if you don't, you will have misleading information. You may either overestimate or underestimate what you're achieving. And so here is how you may end up missing or not counting every child. And that is, let's say the problems are before the child comes to your hospital. And you have listened to several of the present speakers today talking about challenges of awareness, challenges of referral pathways, avoiding no diagnosis or misdiagnosis, refusal, abandonment. And all of these, as you can see in the graph below, are examples where the child may not even reach your hospital, not even get diagnosed, and consequently would never get counted, because to get counted, you have to first be diagnosed. The problem may be at a later stage. They have reached your hospital, you are treating them, but you may not have no system. You may have no Excel sheet or no Resonance or no system to document that, or you may do it, but somebody else in your department who also looks after children with cancer does not do it, or your surgeon may not do it, or maybe an adult oncologist who's treating patients is not putting children is not putting it. And sometimes, you may only put those who have limb surgery or non-metastatic cancer and so on. So you automatically start excluding certain patients, and the idea to put in every child regardless of who they are, what they are. The challenge can be at the next step. Now you've put all the information, and the population-based cancer registry is maybe not going to every hospital or not going to every lab and missing some of the key information. A key issue also is, at least in the Indian context, that grade 1 and 2 WHO CNS tumors are not registered in the National Cancer Registry Program. So your polycystic astrocytomas, your craniopharyngiomas, your meningiomas will not get registered and will not be counted, because we were talking about counting. And of course, we know that cancer is still not a notifiable disease nationally, although in some states it is. And then finally, coming to issues around the cancer registry program, and I'm not going into details about that, but the geographical coverage may be small. And I'm just picking 2-3 examples in the next few minutes to show this. Let's look at underdiagnosis. And this was brought in very nicely in a paper a couple of years ago as part of the Lancet Oncology Commission, where they used proxies for access and referral, because they don't have data on child cancer, but they looked at under 5 antenatal coverage, under 5 DPT third vaccine, pneumonia, diarrhea, and whether the kids are accessing care or being referred at country level information. And then when they saw that, they extrapolated this to produce data for childhood cancer. And what this found was this, that if you look at the 4th last bar graph, the horizontal bar, which is the longest bar, you see half of it is in green and half of it is in orange. And what it shows is that for South Central Asia, with India being the most biggest part of this, approximately 50% of kids are undiagnosed in orange. So this is an estimate based on some clever statistics, but this gives you an idea of the lack of access to care. And based on this, we then wrote a paper which came out a year ago, I think, which talked about what are the approximate number of children with cancer every year in our country. Another example, and you have heard a lot about this, and that's abandonment of treatment. And this is one of my favorite papers because it highlights it so well. This is the well-respected PGI, and I really admire them for taking the problem of abandonment head on and documenting it. And so here are 762 children with ALL from their hospital. Each black square or rectangle is a child. Now, when these children come to PGI, out of them, 230 of them, even before treatment start, drop out of treatment. And then after the end of induction, 68 have died and another 35 have abandoned. Through the rest of the 6 months of intense treatment, another 40 have died and 76 further have dropped out of treatment. So by the time the treatment ends, 126 have, or treatment finishes and in follow-up, 126 have relapsed. So the ultimate outcome is out of 762 children, 188 children are cured of the disease and are alive and well. Now, if you look at this, it becomes immediately clear which is the largest cause of treatment failure. In this context, in this setting, it is abandonment of treatment. Now, imagine you did not count these children and you only looked at the top half of this figure, and you would not be so displeased and say, oh, well, I can cure maybe half the patients and half the patients are dying or relapsing. But if you then looked at this, you would say, oh, the cure rate is actually only a quarter. That is why it is so important to count every child. Coming to hospital-based cancer registry coverage, this is some work which we're doing right now. Based on the paper we showed you, if India had children with cancer from each state, the heat map would look like this, with lots of kids coming from UP and Bihar and then Maharashtra, because our populations in these states are bigger. But we've just received data on around 18,000 children with cancer from 55 registries in India, and we plotted them and see what the heat map looks like. So the number of kids being registered in Kerala and the southern states are far more than what would be expected based on the left-handed heat map, while those from other states like UP Bihar are lesser relatively. So if you now plot the 55 hospital-based cancer registries on the map, what you find is that there are only 2 cancer registries in UP and 2 in Bihar, but there are around 6 or 7 in the state of Kerala. So the number of hospital-based cancer registries and the greater coverage they have, they are better at identifying what's happening to the patients, the diagnosed patients and the registered patients. So to ensure every child is counted, we would suggest that there should be awareness, which you have heard about, referral pathways, There should be an abandonment prevention bundle, which should include a number of things. We need to get over the silos of 12-year-old, 13-year-old, 15-year-old cutoffs of what solid cancer, liquid cancer, and essentially have systems which register all kinds of cancer. There should be an HBCR, which can be done by each of us using free softwares in every center where children are being treated. CNS tumors should be registered, and we should advocate for that. And we are excited that a pediatric dedicated population-based cancer registry is hopefully coming up in Chennai. I thank you for your time, and thank you once again to the organizers for the opportunity.
I think we'll take any questions if we have any.
Yeah. Can I ask a question, sir?
Yes.
Yes. Sir, is there a possibility of ensuring every child diagnosed with cancer or suspected with cancer who has not reached the pediatric cancer unit? There is a seamless entry into the population-based cancer registry by any stakeholder. Maybe may it be a government medical officer in a government health facility or a pediatrician in an office practice or hospital practice. Is it possible in comparison with other countries? Is it any clues? Any clues, sir?
So Avinash, thank you. So your question is it possible for every child with cancer, even if they do not happen to reach a pediatric oncology facility, to get registered in the population-based cancer registry program? Is that right?
Yeah, something like this. Sir, for example, now in District Hospital Ramanagaram, they were referred a child diagnosed with acute leukemia to Kidwai. Now, is it possible for the specialist pediatrician at District Hospital Ramanagaram to make the entry in the PBCR, and then later that is followed up in at Kidwai HBCR and linked with PBCR?
So PBCRs are geography specific. So there's a Chennai PBCR, there's a Bangalore PBCR, there's a Delhi PBCR. Most PBCRs are centered in urban cities. There are very few state-wide PBCRs, mostly in the northeast, right? So for a city or for a state like Karnataka or Tamil Nadu, most PBCRs would be in the capital of the city. So a patient who's originating from a district outside the Bangalore area, there is no PBCR for that. However, those hospitals can have HBCRs. And the HBCRs can capture all the information. The only thing which HBCRs can't do is they don't help you in calculating incidence. So incidence and trends in incidence is something which you can't calculate from HBCRs, but outcomes, referral patterns, treatment modalities, etc. can be all captured with HBCRs, and they cost very little. So they are a far more efficient thing to do, and you don't have to wait for the government to bring it out. Every hospital can do it for free.
Agreed.
Sir, it was nice presentation. Actually, I was interested in cancer registry, so it will actually gave a good insight of it. I think
Raman, can I ask one question?
Good evening, Dr. Kurle.
This HBCRs are not, you are using resonance, and it is quite a pediatric cancer friendly platform. But we have not translated that into HBCRs. HBCR of ICMR. ICMR helps to set up the HBCRs. But they are not very pediatric cancer oriented or compliant. What are your views on that? Are you trying to influence the ICMR for making more pediatric oncology specific or compliant data capturing based on your experience with
Yes, thank you, Dr.
resonance?
Kurle. So you're quite right. The HBCR program, because India's 95% plus burden is adult cancer and epithelial cancer, the focus has been on solid cancers. Even hematological malignancies in adults are not that well captured. And as I explained before, a classic example is CNS tumors, grade 1, grade 2 WHO tumors. They are not interested in that, which may be a very, very small number in adults, but for pediatric tumors, it's a significant number. So that is the first thing. The second thing is that they have done some effort recently with Dr. Prashant coming in. There have been some developments, and they have developed some pediatric modules also. Having said that, I think there's still some way to go. And there is no reason why an HBCR cannot be run in addition or in parallel to with somebody else. So if you're in a hospital where there is no NCRP HBCR, you can easily run your pediatric dedicated HBCR using St. Jude's platform, India Pod platform, Resonance platform. There are several platforms now, all of whom are free. If you are in a hospital where there's already one, like in our hospital, we have an NCRP HBCR platform, because its functionality is not suited to pediatrics, we still keep a separate pediatric HBCR and we have more control over it. And I think it's only an investment of a data manager for that purpose. Or in the early days, even just the pediatric oncologists doing it by themselves till they get some numbers. So my view is that HBCR investment is a small investment on of great value over the years, which all pediatric oncologists should endeavor.
I agree with you totally, but I think we should make an effort through INPOG to make a pediatric oncology platform for HBCR, because ultimately when HBCR gets deposited into NCPR, we will be noticed by the government, because all the cancer control programs are derived or are based on this data. And that is why it is easy to use resonance and have your own method of capturing the data, follow it diligently. All pediatric oncologists are very good at that. But I think time has come, Raman, you should take a lead and do something so that we are noticed in the cancer control program. We are nowhere in cancer control program.
I agree, Dr. Purna. Thank you.
Is any more questions? I think Sakshi, we can you can introduce Dr. Kurkure. I don't think she needs any introduction.
Well, of course.
Yeah. Can I share my screen?
Sure, Dr. Purna.
You have enabled my screen sharing. I hope I can share my screen well.
Yes, ma'am. Just 1 minute. Sakshi will need just 1 minute, and you can then share your screen. Sakshi.
Sure. So as we were talking about, Dr. Purna Kurkure doesn't need any introduction, but still I would like to introduce her. So Dr. Purna Kurkure has an overall experience of more than 4 decades. Her expertise lies in the pediatric solid tumor, late effects of therapy in childhood, cancer survivors and cancer survivorship, and has been a faculty in the reported Tata Memorial Hospital and was the president of International Society of Pediatric Oncology. Also, she started Late Effect Clinic and Childhood Cancer Care Survivor Support Group, and she holds more than 150 national and international publications and is actively working towards the welfare, especially for the pediatric oncologist. So over to you, Dr. Purna.
Thank you for the kind introduction. Am I audible?
Yes, ma'am.
Yes, ma'am.
And is the screen visible?
Yes, we can see your screen.
Okay. Dr. Monica has given me the topic, which is very dear to my heart, as to how you can have better survival and survivorship. So I put it together as optimizing survivorship care in pediatric oncology for today's discussion. And I'll be brief and I'll go through fast. I know this whole exercise, which has been done under the umbrella of CKSOS, is in continuation of International Childhood Cancer Day celebration, which happens on February 15th every year. And it is a global collaborative campaign to raise awareness about childhood cancer and to express support for children and adolescents with cancer, the survivors and their families. And this year's theme is Better Survival is Achievable Through Your Hands, by the right care at the right time by the right team. And this is very important. My all predecessors have talked about the diagnosis, right care, referral pathway, so on and so forth. So we hope to achieve a better survival. And this has been shown that by this exercise, Western world has already, developed countries have already achieved a 5-year survival rate of almost 83.9% as in SEER data. Uh, uh, you can achieve as high as 83.9% overall. And in some of the cancers, it goes in excess of 90%. So as you can see, there is a high curability for all the childhood cancer. And as the cure rates improve, we have to think about quality of survival, and it becomes very, very significant. And it amounts to complete cure and not just freedom from cancer, particularly in children who have the whole life ahead of them. So at each stage, the pediatric oncology has to balance the risk of treatment modality in hampering the quality of life versus the contribution of that treatment modality towards cure. So we need not, we should not overtreat or undertreat at the same time. Overtreating will lead to cure anyway, but have a poor quality of life. And undertreatment, because of the fear of late effects, will hamper the survival. So it's a very delicate balance which one has to achieve to have good survival without affecting the quality of life. Now, this is the magnitude of problem that USA has documented, that in the year 2020, which has gone by, more than 500,000 survivors would be there. And it will amount to having 1 of 530 young adults who are moving on in society between 20 and 39 years will be childhood cancer survivors. This is a very productive years of life contributing to the society. So large number of such survivors are moving on in society and contributing for their own existence as well as the betterment of the society. Now, as you said, as we have already heard that there is no such definite estimate can be made, but if you estimate that you have around 60,000 to 70,000 new cases of childhood cancers annually, and as has been documented by Dr. Raman, that we are achieving around 20 to 25% survival, taking subtracting all the abandonment and deaths and relapses and not reaching the cancer centers, all of them, we may not be achieving more than 20-25% survival. But still, it forms a very significant number of survivors being added to population every year. And that is why there is a need for understanding about the childhood cancer survivorship. Now, as per the National Coalition of Cancer Survivorship and NCI Office of Cancer Survivorship, an individual is considered a cancer survivor from the time of cancer diagnosis through the balance of his or her life. So that cancer experience itself is enough to label a cancer patient as a cancer survivor, because first he fights with the disease to become a survivor, and then he is a true survivor. So in children, we consider disease-free survival for at least 2 years after cessation of therapy, or 5 years after the diagnosis as a long-term survivors. And what we are talking is about the long-term survivors. As we all know that cancer treatment comes with the toxicities, acute toxicities, which are well documented, can usually be anticipated, and there are often offsets. These are often offset by period of good health, because between the two cycles, generally children bounce back and they have a good quality of life in that period. While the late effects have been documented in the last 20-30 years, the information is still coming up and it is not complete in all its form. Many could not have been anticipated when we treated these children, and it can compromise the health of our entire lifespan. The challenges are going to be much more now when we are using more precision molecules which targeted therapies, which we have to continue over a long period of time, and how to measure this late effects of such molecules. That is a different, as we have known the 3 modalities of treatment by now, the further challenges have emerged of these newer modalities. And basically, late effects are not a straightforward cause-effect relationship, because it has an interaction of host factors, tumor factors, and treatment factors. Not everybody who is receiving the same treatment ends up having a late effect. So it's an interaction of these 3 which decides the late effect. And therefore, it is not direct cause-effect relationship. Thus, the consequence of cancer survival can be physical, anatomic, or functional changes. It can be organ toxicities, morbidities that lead to premature onset of chronic illnesses. For example, if you have an irradiation to the heart or the lungs, you can have more of a problem of cardiac events earlier on in 3rd and 4th decade of life, rather than as an aging process. So we say that the senescence which goes with the aging, organ senescence, becomes premature. And that is why you see the non-communicable diseases which we all talk about happening early on: diabetes, heart conditions, and so on. The psychological disturbances and socio-economic burdens as a survivor are many, and children who were diagnosed as cancer, when they grow up as adults and get to know the disease that they have undergone the treatment for, it's really disturbing, and they go through the second phase, because as a child, we believe in breaking the news, but they may not have perceived when they are very, very young, below 5 years of age. And when they get to know their diagnosis after becoming adolescent and adult, it has a lot of impact. And this population has an increased risk of second malignancy. It says that almost 12 to 20 times more than the normal population. So in this whole cancer care continuum, we talk about prevention, which is generally not the case for childhood cancer, because primary prevention for childhood cancer is not possible, but as it is not lifestyle related. Early detection, people have talked about having early detection, how to suspect and how to steer them for early diagnosis. There are no screening methods available, as there is no pre-phase for these cancers. Diagnosis and treatment at a good tertiary center is a must. And then comes, with a good diagnosis and treatment, you have a survival, which has to be discussed under survivorship, which entails long-term follow-up, late effect management, rehabilitation, coping mechanism, and health promotion activities. And end-of-life care for those unfortunate small percentage, at least in pediatrics, 10 to 20% are expected to have the relapse and the end-of-life care and palliative care. And for any advanced case presentation, it may be palliative care may be move upwards. So as you can see, this survivorship has become a very important component of this whole cancer care continuum. And thus the survivorship has been as a recognized entity in this whole trajectory. And the survivorship program's mission has been identified by the survivorship office of NCI. And the mission of survivorship program is to address the outcome of cancer and its therapy and improve cancer survivors' health and quality of life through integrated programs in patient care, research, prevention, and education. So looking after survivorship is not only the well-being and a social aspect, but it has a medical and a research part also, as to how one can further improve the outcomes and a better quality of life. So it's an integrated approach and not in isolation. So if you have to have a development of a good survivorship program, the phase 1 will be to have an infrastructure development, and phase 2 will be professional education and research, and phase 3 will be public awareness and advocacy program. I would say that we are still in phase 1, and phase 3 has taken off, like we are here in developing the infrastructure, and while we develop the infrastructure, we also start having the advocacy. The professional education and research, which comes from the treating oncologist, is slowly picking up because so far we have been very busy with the treatment aspect and improvement of treatment aspect, because first you have to have a good survival to have a good survivorship program. But now, having attained that, and particularly in pediatric oncology, where we all are very sensitive to these late effects because we are dealing with growing children, that this aspect is also being taken care of through our professional education. And there are two models of survivorship care. Either you have a multidisciplinary care at the treating tertiary cancer centers, wherein you have a patient, you diagnose and treat, you stop this treatment as per the protocol, and you observe them off treatment for first 2 years for the fear of relapse. Then they are labeled as long-term survivors, and they keep coming to cancer centers depending on the risk for late effects now. First is a risk of relapse, and now risk of late effects that the surveillance continues. And you have a community-based program wherein you have a nurse practitioners and a primary care physicians who take over after you have pronounced a child as a long-term survivor for the surveillance, because this is more patient friendly, family friendly, because they don't have to go up and down to a busy tertiary cancer center. But to begin with, we have to get organized at this level. To evolve, the evolution will be into the community-based practice. So just now we are at the tertiary cancer centers. And long-term follow-up program should include at least a single physician interested in late effects, a nurse or a nurse practitioner coordinator, a dedicated time and place, which is very important and a very rare phenomena for all the busy oncologists. And depending on the volume of survivors that you have, at least 2 follow-up clinics a month or once a month, depending on the volume, or more. Like when I started this late effect clinic at TMH, it was only once a week. But now they cannot manage with even twice a week late effect clinic. Comprehensive care and screening for late effects based on the survivor's treatment, referral to appropriate specialist and wellness education. This all forms the part of the program. And as I just mentioned, way back in February 1991, exactly 31 years ago, we had started this clinic at TMH. And the whole concept why we started was that when you have an active patient, disease is keeping him grounded with you. At cessation of therapy, the fear of relapse keeps him back for the checkups and follow-ups. But once you say that you are a survivor, then you need to establish that special bond, and they should feel bound, obliged to come, because they're gaining out of something. So that is how we need to pay more attention to these survivors in a separate place, which doesn't get mingled with hustle bustle of active care clinic or outpatient. And the objectives which were kept in mind is to monitor growth, development, and sexual maturation of survivors, to monitor late effects of therapy, to address psychosocial problems of the survivors, rehabilitation for useful, productive adulthood, which is very, very important, and to keep providing feedback, learning from these experiences for future protocol modification to obviate or minimize late effect. And this is a very, very important. This data collection and following it up teaches you, and it is a research component of the ACT clinic. And it is a multidisciplinary team approach where a pediatric oncologist is coordinating with a clinical psychologist, a medical social worker, interaction with array of healthcare professionals, depending on organs at risk, which need to be under surveillance. And from day one, we said that though we will do the clinical research, this has to be a service-oriented clinic and not just the fact-finding clinic. And the patients, the survivors undergo, there is a summary of disease and treatment defining organ at risk for surveillance. The first consult in ACT clinics takes around 45 minutes, 30 to 45 minutes, because you have to go through those days at TMH, we were not having EMR. Perhaps it will be easier now. History of intercurrent illnesses, measurements of height and weight, and ideal growth charts, and seeing where they are falling, whether they are stunted growth or they are falling into the obesity or metabolic syndrome range. Assessment of pubertal development, cardiac monitoring, if they have received those cardiotoxic drugs and or radiotherapy, and assessment of other endocrine like thyroid and others if they are at risk. So basically defining organ at risk based on the exposures to certain drugs and the modality really matters. Monitoring for relapse and second malignancy, where a good clinical examination and observation of the patient has to be taken into consideration. Assessment of neuropsychological and psychosocial status is very important. Counseling for the risk reducing lifestyle changes, that is, a counseling is very, very important. And whenever they reach a adulthood, and we have to start instilling them the premarital counseling. And psychosocial evaluation will comprise of scholastic performance, psychosocial concerns, employment, marital status, and rehabilitation status. And the late effects that you observe, they get classified, graded. I don't go into the details from 0 to 1, 0 to 4, where 0 is absent. 1, 2 are very, you have noticed them because of your surveillance, but they are easily correctable. While grade 3 is generally more obvious and require more intervention, like cosmetic changes, limb amputation, neurocognitive deficiencies, loss of eye due to enucleation, where you require a lot of efforts to rehabilitate. And life-threatening sequelae are graded as grade 4, and they comprise of mainly 2 things. One is second malignant neoplasm and very, very late recurrence of disease, which is very amounting to less than 5% of the total survivors load. So it remains around 4 to 5%, but it is a very important cause of morbidity and mortality. And this creates this document, whether you call it passport, CanKids says it passport. So I use the word passport plan, but basically it is a document which you should create with medical summary of treatment and recommended plan for follow-up. It is known as SCP, Survivor Care Plan. And this is very, very important because this population, as it is going up, is very mobile. In today's time, you have all the national entrances and students move from one to another place. If they have the document with them, they will be taken care of. And of course, by sensitizing everyone around for observing these things and taking care, it will be possible if you have the information. So it provides internal and external physician as well as the patient with information related to the cancer treatment, late effects which are expected, manifested or expected, and preventive care recommendations, psychosocial concern, and recommended referrals if there is a need. Until I was, the last I analyzed was in February of 2014, when there were 1,614 survivors, and it is a long follow-up which we have observed. And now they have gone in excess of 3,000. Dr. Maya is taking care of them, and ACT clinic is still continuing even after my departure from TMH. So ensuring good follow-up at ACT is very, very important. There is a patient bonding and effective listening is the key. And you have to titrate the follow-up with proximity of stay, time from diagnosis, and associated risk of modalities. There is a grading into low, moderate, and high risk. And those who are low grade can be telephonically followed up. Moderate and high risk, depending on the situation, you can call them annually, biannually for follow-up. Creation of nationwide ACT clinic was my dream, and it is coming through very nicely. And I will just share with you that every pediatric cancer unit, which is busy with a sizable population, survivors population, should incorporate that and sensitize the community around them for this survivorship, so that you can have a shared care model afterwards. And also sensitizing the survivors regarding need for long-term follow-up. You empower them, you give the responsibility to the survivors themselves so that they come back for follow-up and they are not dependent on their parents' wish to come back. And what the survivors generally voice these challenges which they feel are very, very valid. That how do they identify risk and problems, who will assess their cancer related concerns, how do they find a specialist who will take their concerns and symptoms seriously, will they get insurance cover? This is a very important issue which they have on their mind. Will there be any discrimination in job and marital prospects, and what resources are available for long-term survivors in our country? And with these concerns, when these children who were attending ACT clinic, they started talking to each other, they formed this support group called UGAM, as CanKid also has Kids Connect. And the vision is basically to ensure that every childhood cancer survivor finds his or her way to celebrate life after winning battle with cancer, to facilitate their life's journey on correct path and in right direction. And thus the medical late effect clinic, which is ACT clinic, which is a part of pediatric oncology unit of Tata Hospital, today has more ramifications involving many multi-specialities, and it has become a very comprehensive unit with support group like UGAM. And that has taught us a model that what are the components of survivorship program. In West, the survivorship groups, they function in society independently. But I feel that their medical networking is very good and they are taken care of for their medical needs very well and in a comprehensive manner. But such is not the case in India. So we must tag along with a medical care and the psychosocial aspect. Two together will make a more sound survivorship care program. And this has been taught to us by ACT Clinic and UGAM as an example. We all know that survivorship issues in India are not channelized through structured survivorship program. There is no national or state level policy that addresses employment and health insurance problems, no database to measure the outcome of cancer, and more funding and support structures have to be created to take care of this. So from Indian Cancer Society, with whom the UGAM is also registered or working under the umbrella of ICS, we started this project Picasso, that is partnership in cancer survivorship optimization. And the objective is to decrease loss to follow-ups, because only when they are structured around the ACT clinic that there is a tracking and you can have a good follow-up. And that also can be decreased, loss to follow-up can be decreased. Increase awareness of late effects and monitoring for early detection of these late effects for a timely intervention. Encouraging disease-specific support groups. Just now we have a umbrella support group called UGAM, but then we can segregate them into disease-specific groups so that they can share the commonality of the problems. to improve the quality of life and to integrate survivor into mainstream of society. So we are partnered with hospitals to facilitate ACT clinics, to develop the psychosocial and rehabilitation module, and to partner with organization to help survivors to integrate into mainstream. And Tata Memorial Hospital, 3,000 plus survivors, we are not counting here because they have been in existence for a long, long time. So it is not good to count them. But besides Tata, we have started the clinic in Mumbai. We started first at Wadia, Sayan and KEM. At Delhi with Dr. Gauri was doing that. So we got more organized by working with them. Aims also we are trying. We have started functioning. Shankara Hospital in Bangalore, and to that we are going to add the Mazumdar Shaw Cancer Center in Bangalore, Chennai Cancer Institute, Adia, and TMH. We are now taking the next module of AYA, adolescent and young adult, as the next experimentation, because this is also another group who needs a very special attention. And SKIMS, Srinagar also is a part of us. So this is how we are trying to spread out and trying to make this concept more visible. And as a, like we provide from Indian Cancer Society, we are providing the psychosocial aspect we are taking care of. And a champion has to be there from the pediatric cancer units who will take an ownership of this survivors for their medical needs and late effect monitoring. And being an NGO, we have started rehabilitation. And we felt that education is the most important aspect of this growing children, and empowerment through the education will be the best thing to start off. And thus we started, the founder of ICS is Dr. Jasawala. In his memory, we started this scholarship fund in an ongoing basis. It is not just a one fellowship or one-time funds, but for every child, there is a milestone being created depending on where the child is in his educational system. And you work with that child through that with the help of a clinical psychologist, career counselor, to read the milestones and disburse the amount as per the needs and the framework. There is a due diligence team for that. There is a governing council who oversees all this. So it is done methodically, and utilization is done in a very standardized manner. And to the tune of 1 crore 27 lakhs so far we have already disbursed, and it's an ongoing thing, and more people are getting associated because of this process of reaching a milestone. And 49 have completed milestones till 2021. Even in a difficult period of pandemics, we had this system going on. We became online for submission of the application, their mark sheets, their results, and so on and so forth. Everything became online, and we have been able to manage even during pandemics. And 21 are completing now in this academic year. So as you can see, late effects secondary to chemotherapy, radiation, and surgery are common. We have to keep an eye open for this. Optimum cancer-related healthcare for long-term survivors consists of proactive and anticipatory longitudinal care that includes screening and surveillance for late effects and counseling to reduce the risk. Most long-term survivors of childhood cancer do not receive cancer-related healthcare. As you can see, only 5% will have a problem of either second malignancy or late recurrences. Most of them, they need for the other medical problems or late effects. A minority of long-term survivors are followed up at a cancer center. Most primary care physicians are unfamiliar with the healthcare problems of this population, and most survivors are not aware of their risk related to their previous cancer treatment. So all this makes them more vulnerable, and our job is to teach them, to make them aware of all these problems. Targeted education of survivors and coordination of care with ongoing communication between cancer centers and primary healthcare workers is necessary to improve this follow-up and longitudinal cancer-related healthcare of the survivors. So we want them to be not cancer-free, but healthy individuals, healthy, productive individuals who are integrated into the society. And thus we can say that together we can do many miracles, we can create miracles and bring the brighter future for these survivors. Thank you.
Thank you, ma'am, for your talk. Sakshi is highly impressed because she was searching for all doctors, and she's highly impressed by your the work you have done. Do we have any questions? There are no questions from the audience, ma'am.
You can close the session, Monica. I'm the last speaker. I'm always the last speaker because survivorship comes at the end. So I'm used to that, and now you can close the session.
Ma'am, your voice, there's a...
Can you hear me? You can close the session. I don't know.
Yes, ma'am, we can hear.
How do I come out of my... Can you still see my...
You have to stop sharing.
How
yes, you have to stop sharing your screen.
Stop sharing. Okay. Okay, sorry.
Yes, ma'am. So I think there are no questions from the audience side. Do we have any questions from here? No, I guess. So it was actually a nice session, and I enjoyed all the speakers, and it gave me, we had everybody contributed to the thought which I wanted this session to happen. I wanted it on 15th of February, but somehow it got delayed. Now, I would request everyone to please switch on their video so that we can have a small picture.
1 minute.
Sakshi, you can take a screenshot. I think we have Dr. Amita, ma'am, you are there.
Dr. Amita is on mute.
Yeah, I can see her. Okay, no problem. We'll just take a screenshot. Thank you all the speakers. Thank you audience. Thank you everyone for your contribution and coming on this platform and giving good suggestions and insights. Thank you everyone. Thank you Sakshi and thank you Clarinet as well. Without them, we would not have been able to do this. I think
thank you so
Richa
much.
was absent. I'll take a screenshot again. Thank you, ma'am.
Give me 1 minute.
Thank you, sir.
I'll take this.
Thank you. With this, we're ending the session.
Okay. Thank you.
Thank you so much, ma'am, for choosing our platform. And it was a wonderful session indeed. I hope you all have enjoyed this session. And with this, I would like to end the session for today, ma'am.
Thank you so much, everyone.
Thank you.
Thank you so much. And have a nice evening to all of you.
Yeah, thank you.